Jonathan sir. Hello. உடம்பு பரவாயில்லைங்க சார். உடம்பு பரவாயில்லைங்களாங்க சார்.
Good evening, sir.
Sir, good evening.
Sir, good evening, sir.
நீங்க தான் worst. எனக்கு ஒரு இன்ஜுரி ஆயிடுச்சு, அதனால கால் தூக்கி வைக்க முடியல.
சரிங்க சார், சரிங்க சார், நோ ப்ராப்ளம்.
நான் சொன்னேன், இப்பதான் கனகர் சொன்னேன், அன்னைக்கு இங்க வீட்டுல கீழே ஒரு சின்ன தகடு தட்டி,
ஐயோ,
அது கொஞ்சம் கிழிச்சு டைல் போட்டிருக்கேன்.
சரிங்க சார், சரிங்க சார்.
ஊர்ல இருந்து வந்த அடுத்த நாள், அதனால கால் தூக்கி தொங்க போட முடியாது.
சரிங்க சார், சார்.
சார் ஆரம்பிப்பாரு, நான் கேட்டுக்கிறேன் அப்படின்னு பண்ணிட்டேன்.
சரிங்க சார், சரிங்க சார்.
கனகர் கேட்டா நீங்க எப்படி இருக்கீங்கன்னு கேட்டாரு.
சரிங்க சார்.
அவரு ஏர்போர்ட்ல பேசுறாரு.
பரவாயில்லைங்க சார்.
பரவாயில்லைங்க சார்.
சரிங்க சார். சார், ஐ திங்க் நான் இன்னும் ஒரு ஃபியூ மினிட்ஸ்ல எனக்கு கனெக்டிவிட்டி போயிடும்னு நினைக்கிறேங்க சார். நீங்க கோஆர்டினேட் பண்ணிக்கோங்க
சரிங்க சார் ஓகே சார்
என் பிஜி வந்து டாக்டர் வசந்த். வசந்த் இருக்கியப்பா? வசந்த்
எஸ் சார், ஐம் தேர் சார்.
இஸ் தேர் சார்
சரிம்மா, பாத்துக்குமா. சீஃப் பாத்துக்குவாங்க. ஏதாவது
சரிங்க
டெக்னிக்கல்
சார்
ஹெல்ப் நீ பாத்துக்கோ தம்பு. கேக்குதுலப்பா? உனக்கு
ஓகே சார்,
கம்ஃபர்டபுளா இருக்கு?
ஐல் டேக் கேர்.
சரிம்மா.
எஸ் சார், லைக்
ரைட் ரைட்.
பவர் பாயிண்ட் உங்ககிட்ட இருக்குல்ல வசந்த்?
சார்.
தம்பி, பவர் பாயிண்ட் உங்ககிட்ட இருக்குல்ல?
சார் அந்த குரூப்ல இருக்குதுங்க சார், நம்ம பிஜி
இல்ல சார், அவங்க
இல்ல
சார்
அவர்
இந்த தம்பி பிரசன்ட் பண்ணல.
இல்ல அவரு வச்சிருந்தாருன்னா ஸ்டாண்ட் பையா வச்சிருப்பாரு.
நான் அவருக்கு அனுப்பிச்சு விட்டுறேங்க சார். நல்ல ஐடியா.
Sir will send you the PowerPoint, but you keep it as standby.
okay sir, I will also get it.
And open, keep it, because sometimes some people will have difficulty. தம்பி பின்னால லைப்ரரி இருக்கு, உங்களுதா சார்?
ஆமா, இசபெல் லைப்ரரி சார். சரிங்க சார், நீங்க பாத்துக்கோங்க சார். தேங்க்யூ.
எஸ் சார் எஸ் சார்
தேங்க்யூ சார்.
Sir, already one part, like one presenter has logged in, sir. She is already online only.
அவரை வந்து ஒரு ட்ரையல் பார்க்க சொல்லிடுமா. ஃபர்ஸ்ட் வந்து
Okay.
அந்த பாய் கேண்டிடேட் பிரசன்ட் பண்ணுவாங்க, செகண்ட் வந்து அந்த கேர்ள் கேண்டிடேட் பிரசன்ட் பண்ணுவாங்க. Karthik, can you try sharing the PPT, ma? First case will be the RIF, ma. Second case will be the CA brush karna sir.
எஸ் சார் ஓகே சார்
Thank you. அதுல பரானுல் ஹுதா வந்து கொஞ்சம் டவுன்லோட் ஃபீவர் சார், அவர் மட்டும் வர மாட்டாரு. ஜோதி மேடம் வந்து 8:30 வரேன்னு சொல்லிட்டாங்க சார். மீதி ஃபேக்கல்டி எல்லாம் வந்துருவாங்க.
ஓகே சார்
தேங்க்யூ.
ஓகே சார்
Thank you.
ரொம்ப யாரும் ரொம்ப பேசிட்டே இருந்தாங்கன்னா மியூட் பண்ணிருப்பான். பார்த்து அவங்க சீஃப் என்ன சொல்றாங்களோ அதை அப்படியே கேட்டு.
Okay sir.
ரைட்.
Okay.
Karthik, you are good to go. You can share. Even the madam வந்து I think she is coming by 8:50. So you will be presenting second.
Karthik, you start from the first slide.
Yes, sir.
Yes, sir. Is the slide visible, sir?
No, you come to the first slide. It's coming almost 15th slide you are opening.
Yes, sir.
No, I'm not able to see. Kannada sir, உங்களுக்கு தெரியுதா?
Yes, sir.
இல்லைங்க சார்
மேடம்,
Madam,
இல்ல sir.
வணக்கம் மேடம்.
ஆனந்தி மேடம் வெல்கம் மேடம்.
தேங்க்யூ, வெல்கம். எப்படி இருக்கீங்க?
நல்லா
ஏதோ
இருக்கும்.
உங்க புண்ணியத்துல நல்லா இருக்கு மேடம். உங்க புண்ணியத்துல நல்லா இருக்கு மேடம்.
Sir, is the slide visible now, sir?
Yeah, it is
From first
visible.
slide.
Run through the
Yes.
slides faster.
தேனாங்க.
Karthik, run through the slides fastly.
Yes, sir. Yes, sir.
Go to the
Is it visible,
slideshow.
sir?
Yes, go to the slideshow mode and run through it first.
Karthik,
Kartik, are you not
there's a-
able to make slideshow mode?
Yes.
Yes, sir.
Karthik, you go down to the volume button, no? Down there's a volume button, isn't it?
Yes,
Or
yes,
right near that there's a cup.
Yeah,
Click on the
yes,
cup.
sir.
liquor.
I'm in slideshow
Yes,
mode now.
Yeah,
Sir.
yeah. Now you can go through the slides.
Yes, sir.
Just go first. Check it.
Yes, sir.
Not moving.
Yes.
Yeah. Go fast. Go fast.
Just scroll through it.
Yes, sir. Yes, sir. Yes, sir.
Just go through it fast.
Sir, it is moving in my.
Pardon?
Yes, sir. Yes, sir.
Your connectivity is. My connectivity is not good.
Yes, sir.
Not moving.
Yes, moving. Move it.
Yes, sir. Should reconnect once again, sir.
Move it bit fast.
Yes.
Next. Dr. Sanjay. Dr. Sanjay,
Yes, sir.
could you please share your slides
Yes, sir.
and check it?
Sir, is it visible, sir?
No, not it. Yeah, it's coming. Make it full show. Yes. Just scroll through it, please. Sir, good evening, sir. Som Prakash Bastar.
Good evening.
சரிம்மா. சார் ஸ்டார்ட் பண்ணுங்க சார்.
Shall we start, sir?
எஸ் சார். சார் சோம் பிரகாஷ் சார். சார் யூ ஆர் ஆன்.
Sir, are we audible, sir?
Yeah. Please start.
ஆனந்தி மேடம்.
Anandi, ma'am,
Yes, sir.
shall we start?
சார் ப்ளீஸ் சார்.
Sure.
Of course, the ground rules, you know, the candidate has to be allowed to present till the history portion without any interruption. Then the faculties can take over. They can ask questions. Once the history portion is over, the candidate is allowed to present the examination. Once after the examination is over, again the faculties can take over till the management. And once everything is over, we have to give the chance to the candidate to ask any of his doubts that will be clarified by the faculties. This is the ground rule. Sanjay, would you please start?
Okay, sir. Good evening, respected faculty. This is Dr. Sanjay Katragadda, junior resident from the Department of General Surgery. I will be presenting this case under the guidance of Professor Somprakash Basu and Professor Farhanul Huda. I am presenting a case of 65-year-old lady, resident of Muzaffarnagar, UP, homemaker by occupation, presented with the chief complaints of pain abdomen since the past 30 days and lump in abdomen since the past 29 days. Patient was apparently asymptomatic 1 month ago when she started having pain abdomen, which was sudden in onset, colicky in character, localized to the periumbilical region, mild to moderate in intensity, on and off, and was aggravated on food intake and relieved on analgesic medication. Patient does not give any history of any radiation of pain. Patient noticed a lump in abdomen after the onset of pain in the right side of abdomen, which was progressively increasing in size. There is also history of loss of appetite and loss of weight. As per the patient, she lost 2 kgs in the past 1 month, and there was generalized weakness since the past 1 month. Patient gives history of constipation. However, patient was passing flatus and feces. There is no history of any fever, melena, bleeding PR, jaundice, hematuria, bleeding PV, cough, breathing difficulty, skin discoloration or ulceration over the swelling, or any headache. Coming to the past history, patient was is a known case of carcinoma cervix stage 3A, which was diagnosed on 10th of June 2022, for which she has undergone radiotherapy, where she received the last dose on 7th of September 2022. Patient is on regular follow-up from the Department of Gynecology. There is no history of any diabetes mellitus, hypertension, COPD, TB, or any contact history. Patient has undergone tubal ligation 28 years ago, and patient has undergone right-sided PCN placement, percutaneous nephrostomy, in view of right-sided hydroureter nephrosis when she was evaluated for carcinoma cervix, and the right-sided percutaneous nephrostomy was changed thrice, which was last done on 4th of February 2023. Patient was transfused 3 units of PRBC during the course of radiotherapy. Coming to gynecological history, patient attained menopause 12 to 14 years ago. She is a P4L4. All the children were full-term normal vaginal delivered. And coming to personal history, appetite is decreased. The sleep is decreased as due to the pain as per the patient. Patient consumes mixed diet. Patient is a chronic BD and hookah smoker, but however has reformed since the past 1 year. She is a non-alcoholic. And coming to family history, there was no significant family history.
We'll start with the history.
Yes, ma'am.
Okay, come to the first slide, please.
Yes.
Okay, her complaint is pain in the abdomen.
Yes, ma'am.
Right.
Yes, ma'am.
So where was the pain located?
Ma'am, as per the patient, patient was localizing it to the periumbilical region, ma'am.
The periumbilical region.
Yes,
Okay, what was the type of pain? You said it was a colicky pain.
Colicky in character, ma'am. Yes, ma'am.
Right. Okay. So why do you get a pain of that nature?
Sorry, ma'am. Hello.
No, why do you get the pain?
Sir,
Why do you get a colicky pain?
ma'am, colicky pain is generally present whenever
Why do you have a colicky pain?
whenever a hollow viscous hollow tubular structure is obstructed, the tubular structure tries to push the contents within its lumen against resistance. Due to this, the patient generally gets colicky type of pain.
Any other reason apart from that? It might be because of the gaseous distension which is happening within the lumen of the bowel.
Yes,
And
ma'am.
there's going to be the stretching up of the intestinal wall.
Yes, ma'am.
This might be a reason for the abdominal pain. Any other type of pain can be presenting in these cases apart from colicky pain?
Ma'am, patient might be presenting with a dull aching pain if because there is also a lump. If the lump is increasing in size, patient might be presenting with a dull aching pain.
Very good. So dull aching pain might be the usual presentation. At times there can be a colicky pain also, right? Does your patient feel any mass?
Yes, ma'am. She complained of a lump in abdomen, ma'am.
She felt a lump in the abdomen.
Yes, ma'am.
Okay, what is the reason for this lump? How do they feel the lump? Is it actually the mass they are feeling, or it is something more?
Ma'am, as per the patient had initially abdominal pain. Then due to the pain, she noticed a lump. After the onset of pain only, she noticed a lump.
Okay. See, usually in a colonic case, what is the reason why there is a lump which is formed? Is it because of the mass or something more?
Ma'am, there might be a fecolith inside, which might be causing a colicky pain.
See, sometimes the emotion is not being emptied or evacuated. There is going to be a stasis there.
Yes, ma'am.
Okay. So this hard fecal matter might be appearing as if it is going to be a mass. So usually the mass it will not be of the same size. Sometimes it might be variable. So when on a day-to-day basis, when you're going to palpate, you'll be able to observe if there is going to be a change in the size of the mass. Then you have to suspect that there is going to be some stasis, especially if the case is going to be a left-sided colonic pathology.
Okay.
Okay.
Yes, ma'am.
Shall we go on to the next slide? Okay, this patient had a constipation, but however is passing flatus and feces. So what is the type of constipation this patient is having?
Ma'am, there was a decrease in the frequency of bowel movements, ma'am. Initially, she used to pass stools once per day, but however, after the onset of pain and all these symptoms, she is telling she is passing once in every 3 days.
Once in 3 days. Okay. What are the other bowel symptoms which are associated with colonic malignancies?
Ma'am, there might be a spurious diarrhea, ma'am.
Very good. So spurious, what do you mean by spurious diarrhea?
Ma'am, it is not a true diarrhea. There is a increased mucosal secretion which passes down in the form of diarrhea, spurious diarrhea, ma'am.
So what does it contain?
Mucus.
There is more amount of mucus and there is less amount of feces, and sometimes it might be admixed with blood. It is something like a slime of feces. Okay, that is going to be occurring. Why does this happen?
Ma'am, due to stasis of the bowel contents in colonic malignancy, there may be ulcerations in the mucosa, which might and inflammation in the mucosa, which might increase the mucus secretion.
And there is going to be an added action upon the bacteria which is going to be present there, resulting in a stercoral enteritis. Okay, so this will present the spurious diarrhea, right? Any other symptom the patient can present?
Sorry, ma'am.
Apart from constipation, any other gut symptoms?
Ma'am,
in a colonic problem? Other symptomatology, GI symptoms.
Patient might present with altered color of stools, and patient might complain of any fresh bleeding per rectum.
Very good.
Ma'am, and
so there could be a bleeding per rectum, or there could be a melena. So which is common now? In your case, what do you expect, a bleeding per rectum or a melena?
I mean, in cases of colonic malignancy, it will be bleeding per rectum.
Bleeding per rectum. Okay. Why not melena?
Melena is usually due to upper GI bleeding.
Very good.
In case of
so when can a right-sided colonic mass produce a melena? So there will be a change in the color of the stool when you have a right-sided colonic pathology. Though there's not an actually acid hematin production, but still the color of the feces will be dark. Okay.
Yes,
but in the case of a left-sided colonic pathology, usually there will be a frank and fresh bleeding would be noted. So such a bleed is we call it as a hematochezia. Whereas this kind of a bleed, it's almost like a melena. Okay.
Okay.
Right. We'll move on to the next slide. So why do you want to know about hematuria?
Ma'am, in case of colonic malignancy, if the malignancy infiltrates into the underlying ureter, there might present with hematuria.
Very good. Right. Is it only hematuria will be the presenting symptom, or anything in association with hematuria? What other things can be?
Ma'am, there can be a lump in abdomen because of the obstruction in the ureter. There could be hydroureter nephrosis.
No, symptomatology.
Lump in abdomen could be a
pertaining to urinary symptom. Since there is a communication with the gut, there could be a gas which can also escape inside. So that's called as a hematuria. So not only hematuria, there could be a hematuria along with an hematuria whenever there's going to be an infiltration into the ureter. And in a lower, in a left-sided colonic malignancy, there could be a direct infiltration even into the bladder, which can be there. Okay.
In this case, he has already mentioned that there is a previous history of carcinoma cervix, which has infiltrated into the ureter. There is hydronephrosis. So you can say in this case you are written, isn't it?
Yes, sir. Yes, sir.
So why can't you put your answer like that? A previous case of carcinoma cervix with right-sided hydronephrosis You are
Yes.
told the general case, but in your case, what was the cause for hematuria? You asked.
There was no hematuria, sir.
No hematuria. But then why? Madam was asking, why did you ask? So you could have said that one
Okay.
as the reason. Okay, because your case is a known case of CS cervix.
Okay. Yes, sir.
Yes, sir. Shenoy sir or Som Prakash sir, kindly, please. Good evening, Shenoy sir.
Good evening. Can I ask one or two questions?
Yes, sir. Som Prakash sir also is there.
Yeah, just one question to candidate. This pain abdomen 30 days, mass abdomen 29 days. You know, somehow, let us be very frank about it. You can accept that both probably pain at the height of pain, probably patient noticed mass abdomen. Okay. Let us not try to make lesser complication in the examination, number one.
Yes.
Second, when somebody gets the pain and the mass together, what are the one or two possibilities you would like to consider? This is my question to you.
Sir, pain and mass, sir.
Together. According to me, it looks like there is a quality pain and the mass. Both appear together. Yes.
Sir, there could be an appendicular lump.
Umbilical region, na?
Pain is in umbilical region, sir. Lump is in right side of the lower abdomen.
Okay, you are talking about appendicular lump. Does it appear suddenly like that on the onset of acute appendicitis? It won't appear. Yes. Whenever
appendicular mass happens after 4 or 5 days only, you tend to have the mass. It doesn't come.
Yeah. So inflammatory mass which appears, classically after a few days, like that, 3 days, 4 days. What answer I wanted was intersusception. Always remember something. Okay.
Okay. Sir.
When you have a pain abdomen, she is a lady and right leg fossa problem. She has a pain abdomen and she noticed a mass. So right-sided tumors are known for ileocholic intersusception. Is it clear? So you should know this.
Yes, sir.
You are following what I'm trying to tell?
Yes, sir. Yes, sir.
Which are the colonic parts which are known for secondary intersusception? This is called a secondary intersusception. Can you tell me?
Sir, ileocholic intersusception, sir.
Yes, that is one thing from carcinoma cecum. It's notorious. Yes. What else?
Colocholic, sir.
So it happens in somewhere in the umbilical region. You understand, no? So transverse colon also is a mobile structure. So it can also happen from sigmoid area. So these are the few areas you can also get a ileocholic, colocholic intersusception. That is one thing. So apart from this, I just wanted to ask you one more question. Why did you write that no ulceration or the swelling or something? I don't know what you have written there somewhere.
Sir,
On the previous slide.
Suddenly you are bringing system by system. You want to ask one thing about the loco region. Loco region is about the pain. Adam has clarified all this colicky pain, intermittent, comes and goes, all that things. Then comes the mass abdomen. Mass you have written progressive, but we expect roughly, since you have mentioned about the mass, we want to know some size. You would have told you some lemon size, doesn't matter. You say lemon size.
Yes,
you progress of the disease, progress. Once there is loco-regional issues are over, constipation, altered bowel habits, loss of, then comes, don't mix up like a fever. Suddenly you brought melena, then yellow disc eye, then hematuria, then bleeding PV. Already patient is a known patient of carcinoma cervix, correct?
Yes, sir.
That requires a separate discussion. Then you brought out cough. Then you have written skin discoloration over the swelling. Then you have brought out headache. See, you have to present it in such a way. Loco-regional issues, you suspect ileocecal tuberculosis or you suspect carcinoma cecum, clarify first. Once that is done, system by system, you ask some leading questions so that you will have some idea whether I am dealing with the primary problem and then it has gone to some spread elsewhere, etc. So ulceration and skin over the intra-abdominal swelling, don't bring into discussion unless it is really occurred. Okay?
Yes,
These are some few comments from my side.
Sanjay?
Yes, sir.
Could you go back to your previous slide? One more slide.
Prakash wanted to ask something.
Yes, sir.
Prakash,
Yes, sir.
Prakash sir wanted to ask something.
No, no, sir. It is okay. I'm just listening. Please
Okay.
carry on.
Sanjay, go to this previous slide. Sir wanted.
One more slide. You come to the past history, please.
Oh, yes, sir.
Yes, please stay there. See, carcinoma stage 3A diagnosed on 10/6/22. Okay.
Yes, sir.
What is 3A?
Sanjay, you have said it correct. You have mentioned 3A for which he has undergone radiotherapy, one currently on follow-up. Right-sided PCN was placed on 4th just 1 month ago, 1 month ago, isn't it?
Sir, it was placed in the month of June only, sir, but it was has been changed thrice since then.
Yeah, again. So she has come to
See,
you again 1
my
month
point
ago.
is, my point is 3A is involvement of the parametrium, not up to the pelvic wall. Literally speaking, in 3A, there won't be any involvement of the ureter. In 3B alone, you may get involvement of the ureter. That is, it involves the whole of the parametrium up to the pelvic wall. So, if at all you get hydroureteronephrosis, that is common in 3B. Hardly you get hydroureteronephrosis in 3A. That is where I am coming. Maybe it would have changed from 3A to 3B later, for which they would have gone for PCN.
Yes, sir.
That is my point.
Yes, sir.
That's all from my side.
Yes. Madam, what do you say, madam? Is it primary or the one which is coming from the previous one? Because when there is a history, not least 7 months ago, a bit detailed history would have been better, pa.
Okay.
Sanjay,
Yes, sir.
what is your conclusion, pa, from the history wise? What could it be?
Sir, 65-year-old lady presented with a progressively increasing lump in the right side of the lower abdomen with colicky type of pain, sir, with loss of weight and loss of appetite and altered bowel habits, constipation, sir, in the past 1 month.
So you come to any probable conclusion?
Yes, sir, I'm thinking in the lines of malignancy, sir. Carcinoma cecum is by provisional diagnosis, sir. One of the provisional diagnoses.
Okay. Madam, what is it? Yes, sir.
Sanjay, I want to ask you one question. Has been already hint has been given that treated patient with the carcinoma of the cervix with this all this 3A plus ureterohydronephrosis. That means that is on the right side, large mass. So, in the absence of fresh rectum and mucus, can you think of anything else? Just because we are surgeons does not mean that you should say only carcinoma cecum here.
Sir, other differentials include carcinoma ovary, sir.
Why ovary? You have a patient with a cervix, na, stage 3A, just 22, 7 months back, 8 months back, whatever. Yes. What I am trying to tell is there is a ureter obstruction is there by the cervix. Growth itself is possible, very large growth, or with or without lymph nodal mass there, extraluminal compression. You have to keep it in mind, including compression on the colon. So you cannot roll out at this stage. That is what I am trying to tell. Okay, dissemination. Already it is in stage 3A. We have no idea. We have not examined the patient, but we just want to keep you think in that direction also. You understand? There is no bleeding per rectum and there is no melena, there is no mucus. It is only constipation, according to, correct?
Yes, sir.
So that is what I would like to tell. Try to correlate to the previous malignancy. That's all my comments.
Sanjay, can a radiation proctitis cause this?
Sir, radiation proctitis would not present as a lump in the right abdomen, right?
My point is constipation and all.
Sir, it might present with mucus, sir, mucus and bloody discharge, bleeding per rectum.
Not for, see, this radiation has been given how many months back? 5 or 6 months back.
Yes, sir.
Okay, there may be late reactions also, radiation proctitis.
Yes, sir.
Still, you want to have a mucus discharge.
So, there might be stenosis, sir.
Okay, go ahead.
Coming to examination, patient was conscious, oriented to patient was examined in a well-lit room in a ventilated room in the presence of a female chaperone. Patient was conscious, oriented to time, place, and person. Her vitals were pulse rate was 94 beats per minute in measured in right radial artery, regular rhythm, normal volume with no radial or radiofemoral delay. BP was 108 by 64 mm of Hg, measured in right arm in sitting posture. Respiratory rate was 18 breaths per minute and saturation was 98% on room air. She was afebrile to touch. Her height is 154 centimeters, weighing 33 kgs with a BMI of 13.9 kg per meter square. Patient is thin built and her ECOG performance status is 2. Patient has pallor. There was no icterus, clubbing, cyanosis, no generalized lymphadenopathy, no pedal edema. A drainage tube, which was PCN, was present in the right flank was noted, which was draining clear urine. Coming to abdominal examination, on inspection, umbilicus is central and inverted. All quadrants were moving equally with respiration. A horizontal scar of size 1.5 centimeters was noted infraumbilically. Fullness was noted in the right iliac fossa. Skin over the fullness appears normal with no discharging sinus or any fistula. No visible dilated veins, no visible peristalsis or any pulsations. Hernial sites appear free. Coming to the examination on the back, PCN was noted in the right flank with no abnormality noted in the back or the spine. On coming to palpation, there was no localized rise of temperature and abdomen was non-tender. A single hard lump was palpable in the right iliac fossa, measuring 10 cross 8 centimeters, globular in shape with well-defined borders. However, the inferior border could not be palpated. Irregular surface, intra-abdominal, fixed and was not moving with respiration. There was no hepatosplenomegaly. Hernial sites were free. No deformity was noted in the spine with no renal angle tenderness. On percussion, tympanic node was present in the rest of the abdomen with a dull note over the lump. No free fluid was noted. On auscultation, normal bowel sounds were heard and normal in number. On digital rectal examination, rectum was collapsed. No growth or polyp was palpable. No rectum mucosa was smooth with a finger fecal staining was present. On pervaginal examination, no growth or any fistulous tract was noted. Rest of the systemic examinations were not within normal limits. The summary of the patient: a 65-year-old lady who is a known case of carcinoma cervix status post radiotherapy, presented with a progressively increasing non-tender hard lump in the right iliac fossa with well-defined margins, however unable to palpate the inferior margin, with irregular surface, not moving with respiration, with loss of appetite and loss of weight.
So what's your diagnosis from this history, from this clinical findings? You only summarize the case.
Ma'am, my provisional diagnosis is malignancy, ma'am, carcinoma cecum.
You're thinking in terms of carcinoma of the cecum. Okay, what are the findings which is in favor of carcinoma cecum here?
Ma'am, patient presented with abdominal complaints from colicky type of pain with constipation, altered bowel habits, and on palpation, the lump was hard with well-defined margins and with regular surface and was on not moving in respiration, and I could not palpate the inferior margin, ma'am. So I was thinking in terms of malignancy because of the consistency of the lump and the associated features like loss of weight and loss of appetite.
Okay. What could be the differential diagnosis?
Ma'am, gynecological
Any differential diagnosis you want to offer?
Ma'am, I would also like to keep gynecological malignancies, carcinoma ovary or any tubo-ovarian mass, or any carcinoma endometrium or any fibroid as a differential, because I was not able to palpate the inferior margin. So I want to rule out any pelvic pathologies as well.
What made you think in terms of a carcinoma ovary?
Ma'am, it was a hard lump. And I was not able to palpate all the margins. So I was thinking in terms of pelvic mass as well.
In relation with the carcinoma cervix with a previous history, what are the possible diagnoses can be considered?
Sorry, ma'am.
In relation with the carcinoma cervix as a previous diagnosis, what other possibility can be considered?
Ma'am, CA endometrium, carcinoma endometrium can be a possibility.
Pertaining to the RAF mass, still you're thinking in terms of only a gynec problem. Can it be a mass of lymph nodes?
Yes, ma'am. Yes, ma'am. It could be a lymph nodal mass, ma'am.
So that could be sitting over the
Tumor which,
bowel lump, right? And you said on percussion, what was the note you heard?
ma'am, on percussion, on
You said you had a dull.
over the lump, it was a dull note, ma'am.
But if you are thinking in terms of a carcinoma cecum, do you think you will have a dull note, or what kind of a note it will be there?
Ma'am, initially it will be tympanic, but once if it starts involving the entire cecum, it will become a dull note.
So the dullness, you can quantify the dullness. It will not be of a stony dullness type. So what type of dullness will it be?
I'm sorry.
An impaired dullness. Okay.
Okay.
Because the underlying problem which is going to be there.
Okay.
It can have an impaired dullness. And you said your lump is almost.
The problem in your case is that, can you hear me?
Yes, sir. Yes, sir.
See, you have a patient who has got a advanced carcinoma of the cervix, that too right hydronephrosis. And right hydronephrosis to occur with the stage 3A, whatever you are telling. Imagine it would have been a involvement of the parametrium, not only endometrium, parametrium, large nodal mass, complex mass there with the right ureterohydronephrosis. Lower border you cannot make out. So you, even if you know that it is a CA, whatever carcinoma cecum or something, probably when you have a mass where lower border you cannot make out in a female patient, it is that to this type of situation. Obviously, it's an advanced stage of CA cervix, which they have done. You have to entertain the first diagnosis itself as an advanced carcinoma cervix. Cervix means when I say advanced with radiation given, probably it is spread there. That's all. In that order, we'll keep it in mind. That this is my way of thinking. Definitely, in a female patient, we will consider carcinoma cecum. We don't consider any other diagnosis you would like to consider apart from these two. See, now you brought out fibroid, you brought out, it is not required to bring out a 20 differential diagnosis. When you are entertaining CS cervix spreading to the parametrium and all, don't bring fibroid into discussion now, that will be a 65-year lady.
Yes.
Your mind is working in the direction of malignancy. So
Yes.
first possibilities is the order of preference. You want to give CSE come or you want to give CA cervix. That is what other things you have kept in mind.
Sir, it could be a lymph nodal mass, sir.
Same thing will come. So if it is a lymph nodal mass, what lymph nodes?
Sir, it could be
Yes.
external group of lymph nodes.
So there could be those Eilea group of nodes again, where we'll come back to the same cervix, it will come, and then of course colon also with all that thing. Having said all these things, when you have an irregular surface and all, don't try to say a globular mass. Globular is some kind of a nice rounded like that. And lastly, when you can't get a mass where the inferior border is not palpable, number one.
Yes.
Moving with the respiration is totally uncalled for here. You don't bring that movement with the respiration. Okay. You have brought somewhere, no? Mass
Yes.
does not. Thirdly, pervaginal examination, was there any ballotability attempted? I'm not trying to say you should do at least the gynecological notes.
Sir, on pervaginal examination, I couldn't palpate any mass itself, sir.
You have to, you know that it's called an internal ballotment. If you have been able to, if there's a mass, you can push it down, means definitely it is an ovarian. Ovarian, it ballots.
Yes.
That's actually internal ballotment. Okay, renals is always, we call it as external ballotment. Okay. So these are just a few points. And CA ovary and all, yes, you have to also keep it in mind. Not that it cannot occur, but I just want to tell you that when you can't get the lower border, think in terms of gynae, is what I say.
Yes, sir.
Sanjay,
Yes, sir.
you just go back to your slide. One slide back.
Hello, sir. Welcome.
Yeah. Jailal sir, welcome, sir.
Welcome.
Next slide. Next slide. Next slide. Next. 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 Next slide. So I want the slide of pervaginal examination.
Oh, sorry.
See, for your information, whenever you come across a CA cervix, you must not do a pervaginal examination as a first one.
Okay, sir.
The first thing you are supposed to do is a speculum examination to find out whether there is any friable growth or not. That is inspection of the cervix.
Yes,
Once
sir.
after the inspection of the cervix, if there is no friable growth or there is no recurrence, then only you can put your finger inside.
Yes, sir.
So when you suspect a CA cervix, a de novo CA cervix, you must not do a PV as a first procedure.
Okay,
This is
sir.
the point you must know.
Yes,
The
sir.
first thing you are supposed to do is speculum examination rather than pervaginal examination.
Okay, sir.
Then coming to the point of ovarian tumor or ovarian cyst, the ovarian tumor or ovarian cyst commonly is present in the hypogastric region, not in the right iliac fossa or left iliac fossa. Can you say why? See, until the swelling is small and within the pelvis, it may be on the right or left side.
Yes,
Once it becomes bigger and bigger, it has got the space only in the central portion. So it comes into the abdomen from the pelvis through the central region and occupies the central region. That is the hypogastric region, or slightly towards the right or slightly towards the left. Not to the whole of the right iliac fossa or not to the whole of the left iliac fossa. That is for the point for ovarian cyst or ovarian tumor.
Okay.
Yes. The faculties, anyone want to chip in, please? Or you please go to the diagnosis portion.
Hello.
Yes.
Dr. Sanjay.
Yes, sir.
Can you tell me what are all other differential diagnoses when a patient presents with carcinoma cervix, okay, with right iliac mass? Your
No. Hello, sir.
yeah.
Sanjay, is it audible or not?
Sir.
You please respond.
Sir, I couldn't get the question, sir.
Okay.
What are the
Sanjay, can you go back to the examination slides?
Yes, sir.
No, Sanjay, just before that, you have that patient with the cervical cancer that you know that this mass is started appearing. What is the time gap between these two?
Sir, she completed her treatment in the month of September, sir. And it's been around 6 months.
Okay, she has not undergone a surgery.
No, sir, she has not undergone any surgery for carcinoma cervix.
So up to what stage of carcinoma cervix you will give surgery as a first treatment, and when will you give a radiotherapy as a first treatment?
Sir, till stage 1 and stage 2, we'll go for surgery, sir.
Stage 2A, B, both you will give for a surgery?
Stage 2A, until stage 2A, sir.
2A only. So that is means. So how do you know that is responded to the treatment? So radiotherapy. You have any evidence to say that radiotherapy which she has undergone has responded?
She has undergone after
that is why Karnagaran sir was insisting you on to look on the speculum examination and see the cervix and what is the status of the cervix at this present. Is there still the malignancy is there or not?
Yes, sir.
When you think it is a node or you think it is a following the cervix or anything else you are thinking in terms of?
In 600 meters, turn right toward Kamala Street.
You are giving importance as a nodal secondary or not?
Sir, no, sir. Patient was actually under follow-up of gynecology department, sir. And she was under continuous follow-up. And
no. See, no, please do not, because we are now presenting for a surgical department and under your, what use you are finding? Are you thinking it is a sequelae of a cervix or you are thinking it is a separate entity you are getting it?
Separate entity, sir.
Why do you think it is a separate entity? No, what makes you to think it is a separate entity you are getting?
Take the next right toward Kamala Street.
Is it, have you examined that what is the cause for that cervix, carcinoma cervix he has having? What is the reason, etiology for that?
It was squamous cell carcinoma, sir.
During the evaluation itself,
no.
For a CA cervix.
What are the etiology of carcinoma cervix?
Sir, human papilloma virus.
No, if you think it is a human papilloma, have you screened your husband?
400 meters, turn right onto Major District
no,
Road
sir.
248, Major District
No.
Road 834.
Okay. So, what hormone is responsible for carcinoma cervix? What is the difference in that? What type of hormone excess will produce a carcinoma cervix?
Sir, estrogen. Sir.
We know estrogen is only for carcinoma breast. Carcinoma cervix is entirely opposite to carcinoma breast. Whatever factors which is responsible for starting predisposing factors for the carcinoma breast is entirely opposite to that. Nulliparous is common for carcinoma breast, but here it is only the multiparous tumor. And estrogen is there and progesterone is here. So that even project means starting that we have a solid case where we know that it is a carcinoma cervix. You know that it has been treatment is there. I think that's the first thing you must think is whether it is a sequelae of your treatment, then putting into a fresh diagnosis into that. Because it is your finding is a more of don't entertain a fibroid uterus and carcinoma ovary, all those things at this point. You'd have talked with the notes. Okay, go ahead in the examination. Probably you will give more insight into that.
Yes, sir.
Sanjay.
You can go to the examination.
Sir?
Sanjay?
Yes, sir.
You mentioned a fullness noted in the right iliac fossa. Skin
Yes,
over the fullness appears normal. Okay.
Yes, sir.
With no discharging sinus and or fistula. What do you think here? Why you?
Sir, I want to rule out any erythema or any inflammatory pathology, sir, mentioning this.
What inflammatory pathology there? That you are just thinking about any other cause?
No, sir. Right now, though, in the terms of malignancy, I'm thinking, sir.
Yes, that right. You mean to say carcinoma cecum will present with will have discharging sinus or fistula?
No, sir.
No?
No, sir. It does not present, sir, usually.
Huh. Then why did you check this? No discharging sinus, fistula.
Sir, I just wanted to mention the skin over the fullness was appearing normal, sir.
I think that would have been enough.
In the postgraduate, you must say, when you say no sinus, that means there will be some sinus will be there. Do you get any sinus in the abdomen? No, it is not that we don't expect a postgraduate to say it is a routine. Postgraduate should follow what is the particular to the case and what you are expecting for a particular case. Here you are saying, talking about the node, then you are suddenly talking about the fistula and the sinus in the abdomen.
Continue on Thanjavur, Kalayarkoil, Sayakudi Road for 1.5 kilometers.
Can we go to the findings, because we are getting late to talk about your local findings of examination.
Yes, sir. Well.
So how you are going to manage your what is your probable diagnosis you are making? First probable diagnosis.
Sir, I'm thinking in terms of fecal malignancy, sir.
Okay, how you are going to proceed?
Sir, to see, to look for the origin of the mass, sir, I would like to get ultrasound done, sir, to see if it is arising
He's
from.
completed his examination.
Sir, I want to get a.
You are completed your examination?
Yes, sir.
Yeah.
So
you want to get an ultrasound done?
Yes, sir.
Okay.
To see if it is arising from the bowel or is it arising from the pelvic pathology, sir, or any nodal mass.
Ultrasound will be able to tell you the mass is arising from the bowel.
Sir, it can rule out the pelvic pathology, sir, or any lymph nodal pathology, lymph nodal mass.
So if there is a lymph node, you will rule out carcinoma cervix. I mean carcinoma from the cecum.
No, sir. It can still be, the lymph node can be due to the carcinoma cecum as well, sir.
So what you want to know on ultrasound? What is your intention of doing an ultrasound?
Sir, to see where the mass is originating from. Sir.
Okay. So, is it this enough? Ultrasound will not confirm. You will give an idea about that where it is arising. So, what is your next line of management you are going to do?
Only the site of origin you'll be picking up in an ultrasound, or anything else you can pick up in an ultrasound.
Ma'am, we can also pick up any metastatic lesions in the liver.
Okay. Then, apart from that?
Any free fluid, any ascitic fluid can be noted.
Right. So not only looking into the primary, you can try to look for any other secondary things or any other. Already I said there is going to be an hydronephrosis. You can see the status of the pelvic calyceal system in the kidney. Okay. And
Yes,
apart from that, you can look for your metastatic features like looking into the liver for any deposits which are present there, or anything which is present, right? Lymph nodal enlargement, parietic group of nodes that are enlarged. All those things can be picked up with your ultrasound if you're able to find it out. Okay.
How do you make out hydronephrosis by ultrasound? What will be the finding of hydronephrosis in ultrasound?
So the pelvic calyceal system will be deranged with a loss of corticomedullary junction.
What will be the size of the kidney?
The kidney will be enlarged, sir, with the loss of corticomedullary differentiation.
What is the normal size of the kidney?
Why should there be a loss of corticomedullary differentiation? There will be a thinning of the cortex. Okay, there will not be a differentiation will be made out because there is going to be a fluid within the calyceal system. Definitely you will be able to differentiate between the cortex and the medulla. This corticomedullary differentiation will be lost only if you are going to deal with the medicorenal disease.
Okay.
No, that is the reason why I asked, because the most of the postgraduates they just say it's a hydronephrosis. You will find out with the ultrasound without knowing what exactly that you are going to look in hydronephrosis in ultrasound. Given the size and where the corticomedullary differentiation, what will be the shape of the calyxes you are going to see. So this all ultrasound is a basic investigation which every postgraduate should know. It is what you are going to see. It is the fundamental, the type 1 or the grade 1 type of ultrasonography. Everybody should know. Okay, you have seen then any other investigation you want to know?
Sir, then I would like to, if it is arising from a bowel pathology, sir, I would like to get a colonoscopy done, sir. Colonoscopy guided biopsy. Or else if, and to further better delineate the disease.
What are the steps you take to prepare the bowel for colonoscopy?
Sir, patient will be kept on a day prior to the colonoscopy. Patient will be kept on liquid diet, sir, and patient will be given a peg leg.
What is peg leg?
Sir, it is a hyperosmolar solution, pegylated, sir.
What is the pharmacological name? So when will you give the peg leg?
Sir, it is given on the evening before the colonoscopy, sir, once, and on the day morning as well, sir. On
two doses you are going to give. Okay.
Yes, sir, 2 doses.
So you give peg leg, but do you watch for anything whether the patient is passing stools or not?
Yes, sir. Patient will be passing. There might be loss of. There might be loose stools, sir. So there might be any electrolyte abnormality. So we'll have to keep a watch on our electrolytes.
In a patient with a constipation, you think you can give a peg leg?
No, ma'am. It can aggravate the obstruction more, and it might lead to more colicky pain, and patient might land up in frank obstruction, ma'am.
Only obstruction, or something more will happen. Disastrous things can happen. You can perforate. So you should see whether there's going to be an absolute constipation and there's going to be a complete obstruction. In those cases, you're not supposed to give any peg leg.
So what you are expecting if it's a carcinoma?
Sorry, sir.
So you have done a colonoscopy. What is the length of a colonoscopy?
What is the finding you are going to expect in the colonoscopy when you are doing?
Sir, there might be a proliferative mass in the cecum, sir.
Have you done?
Hello, sir.
Have you been or assisted any colonoscopy in done?
Sir, I have seen, but I have not assisted. Yes.
Okay. So madam has asked what is the length of the colonoscope, or up to what level?
120 centimeters. No? Around.
Any finding you are expecting that?
Sir?
Thing in terms of cecal carcinoma.
Yes,
You are
sir.
thinking in terms of the cecal carcinoma. So what is the finding you are expecting? You will look for that. What are the findings you look for that?
So there might be a proliferative mass in the cecum, sir. With ulcerated mucosa as well.
What is the type of growth you expect in a carcinoma?
It's a proliferative growth, man.
Proliferative growth.
Sir?
You are going to get only a proliferative growth in the carcinoma cecum. So you don't get an ulcerative lesion.
Ulcerative lesions as well, sir.
No, don't expect the examiner to tell the answer.
Yes, sir. Sorry, sir.
So you can have an ulceroproliferative type of growth, which is most common, and it is going to be little bit in the proximal colon. Then you can have a what kind of other types of presentation can be there?
There might be
The ascending colon or in the descending colon. What will be the type of presentation?
there might be synchronous lesions, ma'am.
Okay. Now, what will be the type of presentation? You said ulceroproliferative in the carcinoma cecum. What will be the type of presentation there? In the ascending colon. Sometimes you can have stricturous kind of lesions also. Okay. Flat lesions are more common along the right side colon, and proliferative lesions are more present on the left side of the colon.
Yes, ma'am.
Okay, having done a colonoscopy, you have taken a biopsy. What kind of what report you expect?
Ma'am, it can be a adenocarcinoma of cecum, ma'am.
Okay. Now, what do you want to do?
What will be the histological finding?
Adenocarcinoma, sir.
If to say it is an adenocarcinoma, what will be the histological finding?
Sir, there will be tubular glandular structures in the mucosa, producing with mucus, filled with mucus, sir.
Mucus. So what is the cells in the normally present in the colon?
Columnar epithelium, sir.
Colon epithelium. What is the special cells you have in the colon or intestine?
Goblet.
Goblet cells. So where it will present?
Okay, while doing a colonoscope, you find out lot of polyps which are seen.
Yes, ma'am.
Now, what are you going to do?
Ma'am, we have to get it tested. The patient tested for any familial malignancy as well, if there are many.
You are doing a colonoscopy. You are seeing a polyp. What test you are going to do? Will you do a biopsy?
Yes, sir. If the polyp is pedunculated, we can do a polypectomy, sir.
So if it is no, I'm taking a biopsy. You are not asking for the polypectomy.
Yes,
Suppose
sir.
it is sessile, what do you do?
So we can take a biopsy, sir, from the polyp.
How do you take a biopsy?
What are the different types of polyps you can see in the colon?
You already said the pedunculated, sessile,
Yes,
any other type polyps? What is hyperplastic polyp? What is adenomatous
You can have a
So
tubular
your
polyp
biopsy
or
has proved
villus
it is
polyps,
an
right?
adeno.
Or a tubular villus type of polyps can be seen.
Yes, ma'am.
Right. What are the some syndromes?
Is there any significant on that? Whether it is a tubular polyp or a tubular villus polyp or the villus polyp? Is there any significant on that?
Sir, increased the probability of malignancy in a villus polyp, sir, when compared with a tubular polyp.
What is the probability?
Sir, around 5% in villus polyp, sir.
Villus. It's extremely high. Huh? Villus polyp is more than 40%. Malignancy will always preceded with a polyp somewhere. And if
The
the PR
percentage of
analysis, you
malignancy in a
can
villus polyp is more. Okay, it is not 5%.
Yes, ma'am. Yes, ma'am.
So having diagnosed it's a carcinoma, is also proved, biopsy also proved. How well will prove it? Because already it is 1 hour is over. So you need to go for the management.
Yes. Sir, then if it is a proven malignancy, then I'll have to stage the disease, sir. Staging, I can do it by getting a CT, thorax, abdomen, and pelvis done.
You think it's the second primary?
Sir, sorry, sir, I was not able to get you.
The patient is already having a carcinoma cervix. Now
Yes, sir.
you are finding out a second primary. Having carcinoma cecum. Carcinoma cervix is common.
Sir, your voice is breaking.
I'll say it is a second primary. What is the criteria to say a tumor is a second primary tumor?
Sir, I'll have to read.
Okay.
Carcinoma, there is a cervix. Now there is a carcinoma in the cecum. How do you say this tumor is not a metastatic problem, or it is going to be a second primary, which has happened in the cecum?
Ma'am, biopsy might help us, ma'am.
You've done a biopsy, it has come as a adenocarcinoma. Then?
Yes. To further characterize the lesion, we can go for immunohistochemical markers in the biopsy.
See, you can do the certain tumor markers. What is that? The CA cecum.
CA we can get done.
Okay. That will not be positive. It's going to be a metastatic deposit. Okay. Right? If it's going to be a primary, you can do a CA and you can confirm that it's only from the colonic problem. And moreover, in the histopathology, if it's going to be from metastatic deposit, it will be having a look of that of the primary, which has already been present. Okay.
Yes, ma'am.
In the cervix, it is going to be a squamous cell type of lesion.
Yes, ma'am.
So it should be, here it is an adenocarcinoma. So definitely this is going to be another type of primary. It is not a metastatic deposit.
Yes, ma'am.
Okay. Right. So they have done a staging workup. So now what do you want to do? This patient doesn't have any other metastasis except for a primary in the cecum. Now what do you want to do?
Ma'am, we'll have to go for we'll have to also look for the resectability of the tumor, ma'am, if it is getting infiltrated into the surrounding structures or not. And then we can plan for operative management.
Dr. National Highway 36.
What is the age of the patient?
65-year-old female, sir.
Do you think it's a possibility of a Lynch syndrome is there?
Sir, there can be a possibility because there's already a case of CS cervix, and with a colonic malignancy, we should also consider for a familial malignancy, sir.
So Lynch syndrome will produce on a right-sided malignancy or left-sided colonic malignancy.
Lynch on the right side, sir.
Good. So right side. So FAP will be on the left side.
Left side,
So you
sir.
must rule out there is a possibility, but the age is 65. So we do not normally entertain at the age of 65. When you are making a diagnosis less than, and there is a Milch-Chowdhury criteria to say that what is the second primary tumor, that's all fine. Now you have made out it is a carcinoma cervix. Patient already undergone a CS cervix treatment. Now what is your options you have for the treatment?
Sir, operative, we can go for a right hemicolectomy, sir.
So you will not do the metastatic workup?
Sir, I already mentioned, we have to get a metastatic workup done, sir.
Okay, sir. Why do you want to do a CEA?
Sir, CEA, it can be used in the follow-up of the patient, sir. Sir.
So what is non-secretase of CEA?
Sorry, sir.
What is non-secretase of CEA?
Non-secretase.
Okay, there are group of people, there's a percentage of persons,
okay.
They will not secrete CEA at all. So that is
Okay.
why the reason why always you do the pre-operative, though it is going to be used only on the post-operative. Pre-operatively, you should do the CEA level. So what is the significant value of the CEA you are going to aim at?
Sir, greater than 5 nano gram per deciliter, sir.
Suppose it comes as 100 or 150. So what do you think possible?
Sir, colonic malignancy we can think of, sir.
It is already you have made a diagnosis of colonic malignancy. CA is not going to help you to make a diagnosis.
Yes, sir.
Suppose he has a liver tumor, secondaries, operating on the liver secondaries, it depends upon the CA value also.
Okay.
Okay. So now you have no liver secondaries and you have only a CA cervix. And what is your plan? CA-CCAM.
Yes, sir. We can go for right hemicolectomy, sir.
What do you mean by that?
Sir, in a right hemicolectomy, sir, we remove the terminal part of the ileum, sir, about 20 centimeters of terminal ileum with ascending a
So
sequence.
how do you decide it's a 20 centimeter?
Sir, that is actually intraoperative finding, sir. When we ligate the ileocolic artery, we have to see the we have to remove the part until the ileum that is not perfused.
So that is your criteria, not your 20 centimeter or 15 centimeter is not the criteria.
Yes,
so
sir,
you are going approach and ligate the vessel, and whatever the vessel part of the bowel is gangrenous, you are going to remove, or the ischemic changes are coming, you are going to remove that.
Yes, sir.
So what are the sophisticated method to assess the vascularity?
Sir, indocyanine green we can use, sir.
Okay. So what
are the
structures
vessels
you will
we
go for the?
Ma'am, we ligate ileocolic artery, right colic artery, and the right branch of middle colic artery.
So what is the technique you prefer to go with when you're planning for a right hemicolectomy?
Technique, ma'am, there could be lateral to medial or medial to lateral.
Which would be the better one?
Which one you prefer?
Sir, medial to lateral will be better for malignancy, so that we can take control of the vasculature initially, so that there won't be any tumor shedding, sir, while we are manipulating the tumor.
What is Turnbull's technique?
Turnbull is a no-touch technique, ma'am, where we initially separate the colon from the. It is medialized. It is separated from the peritoneal fold of tissue, and then we clamp the vasculature, ma'am.
So where do you mobilize? What is the first line of incision you make to mobilize the cecum?
Ma'am, we have to identify the white line of Told, which is in avascular plane, and along the white line of Told we'll be starting.
Right. So what is the precaution you like to take when you're going a little bit higher up?
Ma'am, we'll have to be cautious about the underlying structures like ureter, and also about the duodenum.
Are you worried only about the ureter?
Duodenum as well, ma'am, when we reach high up.
Only those two, no other pictures.
So the ureter, you said, after that, what is the next thing?
Duodenum, I said, ma'am.
Duodenum, very good, right. So the chances of the duodenum getting injured is very common whenever you are going to reach the hepatic flexion. So
Yes,
try to take care, and apart from that, you have to look for your gonadal vessels also when you are going to do this,
yes,
right?
yes.
Like having done a hemicolectomy, now what kind of anastomosis you want to do?
Ma'am, we'll have to do a iliotransverse anastomosis, ma'am. That we can do it end to side or side to side.
Right. If your patient is presenting with an acute presentation, what do you like to do?
Ma'am, if the patient is in acute presentation, I would like to get a ileostomy done to relieve for the obstruction. In case of emergency, I would like to externalize the bowel, ma'am, by doing an ileostomy.
In case of emergency, or how do you tackle?
I'll externalize the bowel by doing an ileostomy. If the patient is presenting in with obstruction, acute obstruction.
Okay, you're going for a resection followed by an ileostomy.
Yes, ma'am. Yes, ma'am.
That was the answer?
Yes, ma'am. I can, ma'am, ileostomy itself, and the final this thing we can do it in the next sitting, ma'am, dissection.
Next sitting. Then until the time, how the bowel would be draining out?
You will do only ileostomy and come back. You will not do the resection. Okay.
Yes, sir.
So what will be the pathologist? You have sent for a specimen. What are the things you look in the pathology?
Sir, we'll have to look at the margins of the tumor, sir. Margins are free. We'll have to look at the number of lymph nodes that are sampled in the tumor.
What is how many mandatory lymph nodes to be removed?
Sir, 12 lymph nodes, sir. And we'll also have to look for any lymphovascular invasion, sir.
The pathological staging of a carcinoma cecum.
Sir, histopathological staging, sir.
Yeah.
Sir, on the basis of the layers that are involved by the tumor, we can get the tumor T staging done, sir. If the tumor is invading the submucosa, it is T1. If it is invading
I'm asking
N, sir. Yes, sir. On the number of the lymph nodes involved, we can divide it into two, sir. N1 and N2. N1 is again divided into N1A, N1B, and N1C. And
what is N1C?
N1C is a deposit in the pericolorectal tissue, sir, but it is not a lymph node.
What other carcinomas will have a N1C? You have come across N1C in what other carcinomas?
N1.
Especially this is the lady. You have differential. No. So it's comes under the stage 2.
Yes, sir. Hello, sir.
If it is coming at the stage 2.
Yes, sir.
Any post-operative follow-up you'll give or you'll leave it?
Sir, adjuvant chemo is generally indicated from stage 3, sir.
What chemo?
Sir?
What is the chemotherapy you use?
Sir, we can use FOLFOX regimen, sir.
What is the combination?
5-fluorouracil, leucovorin, and oxaliplatin, sir.
What is the comp? What is the complication? What are the complications of that?
Good evening, sir. Senior faculty. Good evening, sir. Sorry, I was a bit late because of travel.
Complications of chemotherapy, sir.
Yeah. Each drug, okay.
Sir, I'll have
So,
to.
how do you think is the prognosis of this patient?
So prognosis is good, sir, if it is a stage 2 disease.
Good. A patient
So
already
how do you
undergone
plan to follow up this patient?
Ma'am, I would
You
like
have done a surgery, now done a hemicolectomy, everything went on well. How do you plan to follow up this patient?
Ma'am, I would like to get a CA done every 6 monthly for the next 5 years to see if there is any recurrence or not, ma'am.
So you're thinking only in terms of colon pathology. He has
Sir,
already got one CA service and one CA here. Do you think want to plan for anything more?
ma'am, I
What is the
also
role of upper GI endoscopy here?
I'm not sure.
You already done a colonoscopy, you have seen a polyp. Is there any role of endoscopy?
Sir, duodenal polyps or gastric polyps can also be there, sir.
So patients can have duodenal malignancies, as you said, right? Or any gastric malignancies also the patients can have. So you need to evaluate these patients not only for your colonic problem, you need to evaluate for other systems which can get also involved.
Yes, ma'am.
Okay. So extra colonic manifestations can be possibilities in these patients, not only a colonic pathology. Especially this patient, he said there is a CA cervix which has started initially.
Yes, ma'am.
Sanjay,
Yes, sir.
What is
he's
it?
already on radiation, radiation therapy, RT.
Sir, radiation therapy in what, sir?
For CA cervix, okay?
Yes, sir.
Yeah, what do you want to do for that? If you have done hemicolectomy here,
Yes, sir.
how you want to proceed for that?
For CA cervix, sir.
Yeah.
Sir, I would like to see the status of the disease currently, sir. I would like to get a CMRI done, CMRI pelvis, to better able to tell about the lesion.
Okay. You want to once again check for this CA cervix, which stage it is, then
Yes.
you want to continue the treatment?
Yes. Sir, if there is any lesion still persisting, then I'll have to continue the treatments.
Okay.
What treatment? What treatment you will be continuing? So this case already has undergone a radiation. What kind of difficulty you will face in doing hemicolectomy?
There might be adhesions, sir. And
Adhesions? Flimsy adhesions.
yes, sir.
So radiation will produce flimsy adhesion.
Dense adhesions, sir, in the pelvis might be there, sir. And there might be radiation-induced enteritis.
So what will be the finding?
Bowel mucosa might be friable, sir. Erythematous and friable.
So your anastomosis has to be extremely cautious. Otherwise, you will have a difficulty in that.
Yes, sir.
And even mobilization will be difficult because the plane may not be go in an appropriate plane.
Yes, sir.
And ureter, everything, so you need to be extremely cautious in a previously rated. So will you do a simultaneous hysterectomy or not for this patient? Suppose if it is two entity, separate entity.
Sir, I'm not very sure about hysterectomy.
Okay. Okay. It is better to go. Good.
Okay, sir.
Yes, after hemicolectomy.
Yes, sir.
Sanjay?
Yes, sir. Yes, I'm listening, sir.
Yes, you have done a hemicolectomy, and how you want to proceed now? Is there any other treatment options you want to do? If it is
So if the stage of the disease is higher, then I will have to start the patient on adjuvant chemotherapy, sir.
okay, what adjuvant chemotherapy?
Sir, Folfox regimen can be given, sir.
Okay.
When Sanjay, when else will you like to give chemotherapy? Even if the tumor is
Sir, if the
not-
lymph sampled are less than 12, then also we'll have to go for chemotherapy, sir.
Yes.
And if the pathology, histopathology of the tumor is very poor, then also we'll have to go for chemotherapy, sir.
So if the lymph node harvest, if it is less than 12, that's a mandatory indication of adjuvant chemotherapy, even if the tumor is not advanced, locally advanced, right?
Yes, sir.
Okay, what are the problems which can happen after a hemicolectomy?
Ma'am, the main complication we are concerned in this case would be anastomotic leak, ma'am.
Okay.
Yes, ma'am. And there might be.
What will be the long-term problem?
Sorry,
When
ma'am.
there is no terminal ileum, what are the long-term problems you are going to get?
Sir, the patient might be having vitamin B12 deficiency in the future because of the lack of terminal ileum. So we'll have to.
B12.
And yes.
B12 is the main site of absorption of the B12 is ileum?
Sir, terminal ileum.
No. The
Okay,
terminal
apart
ileum,
from
what are the main things you talk about terminal ileum?
Sir, bile salts as well, sir.
Okay, very good. So bile salts absorption with that sort, what is the complication of that?
Sir, by common indication of, sir?
Now, what is the
when bile
complication
salts are
of that?
not getting reabsorbed there, what will happen?
Sir,
Will there be any mismatch which might result in something?
there might be cholelithiasis, ma'am, because
Very
of the
good. So,
bile salts absorption.
I think we are. Kanagavel sir, we are getting time now.
No, thank you.
Kanagavel sir is not there.
I think Karnal sir is the moderator.
You have any questions?
Can you come close the session?
Yeah, we can close this and go for the next minute. Because already it is 9:20. It is late.
Okay.
So do you have any questions?
No, sir.
Okay. So thank you for a good presentation. You are well composed and studied well. So congratulations, and we'll go for the next presenter.
Thank you, sir.
Sanjay, you did a fabulous work. Only thing, whenever you have a coexisting problem, always try to relate your current issue with the coexisting problem. Okay. A separate diagnosis as a first priority, usually people don't entertain in the examination. They try to relate it with the current problem, which is something existing together. Okay.
Okay, ma'am.
So that might be a second primary, but still people will want to relate those two things together. Okay.
Yes, ma'am. Thank you, ma'am.
Thank you.
Sanjay, would you please disconnect your slide?
Oh, yes, sir.
Karthik. Karthik, am I audible?
Yes, sir. Yes, sir. Hello, sir. Yes, sir, you are audible.
Karthik, please upload your slide.
Sir, are the slides visible, sir?
You are yet to see it is coming.
Sir, is it visible, sir?
Yes, we got it.
Go ahead, Karthik. So you can go ahead.
Hello.
You can start presenting your case.
Karthik or Niveda, are you here? You can start presenting. We're not.
You have seen the slide, but not the presenter.
Both the presenters are here, but I don't think what happened to them.
Good evening, sir. Good evening, ma'am. Myself,
Karthik. Niveda. Niveda.
Karthik, you can start with your presentation. If Niveda is not there.
I think there is a network issue, sir. I will correct it. Karthik.
Yes.
so are the slides visible, sir? Good evening, sir.
Of course.
Yes. Good evening, sir. So here is a 48 years lady, resident of Gadak, homemaker, presented to the OPD with the complaints of lump in the left breast from past 6 months, ulcer over the left lower outer part of left breast from past 15 days. Hello.
Yes, audible. You go ahead.
Yes, sir.
Karthik, go ahead.
Yes, sir. Patient was apparently all right 6 months back to start with. She incidentally noticed a lump in the outer part of left breast while bathing, insidious in onset, progressive, which was initially of around 3 x 3 centimeter, which gradually increased to the size of around 4 x 4 centimeter in past 5 months, and then was a rapid increase in the size for past 1 month to attain the present size of around 6 x 6 centimeters. The lump was not associated with pain. The patient complains of ulcer over the left breast from past 15 days, insidious in onset, progressive in nature, initially of 1 x 1 centimeter, gradually increased to the present size of 4 x 3 centimeter, associated with continuous pricking type of pain, with minimal serous discharge from ulcer, non-foul smelling and non-blood tinge. Patient noticed retraction of nipple 15 days back. No history of nipple discharge, trauma to breast, fever, loss of weight, history of loss of appetite from past 1 month, and history of recent onset of back pain from past 15 days. There is no history of breathlessness, cough, chest pain, hemoptysis, abdominal distension, headache, or seizures. There is no history of any other swellings in the same or opposite breast and axilla or elsewhere in the body. Past history, there is no history of hormone replacement therapy or OCP intake, no history of similar complaints in the past or any history of previous surgeries, not a known case of diabetes, hypertension, or tuberculosis. Personal history, mixed diet with decreased appetite, regular bowel and bladder habits, with disturbed sleep from past 15 days due to pain in the ulcer over the breast. No history of smoking, alcohol intake, or tobacco chewing. Menstrual history, age at menarche is 13 years and age at menopause is 45 years, and cycles were regular. Age at first childbirth is 21 years. She has breastfed for the period of 12 months. Family history, no history of similar complaints in the first or second degree relatives. Summary, A 48 years lady with the complaints of lump in the left breast from past 6 months, with rapid increase in the size of lump from past recent nipple retraction and low back pain from past 15 days without any comorbidities.
So all the complications are within 15 days. You have
yes, sir.
Ulcer, you have a nipple retraction. All that happen within 15 days.
Yes, sir.
Yes, sir.
Okay. So what do you think that the reason for that ulcer?
Sir, since the rapid increase in the size of the breast lump was there, there may be stretching of the skin over the lump, which might have led to the ulcer, sir.
So skin infiltration or the stretching of the skin and ulcer?
Yes, sir.
That is not a skin infiltration. If it is the skin put out, so that is not a skin infiltration.
Sorry, sir, I'm not able to hear.
How will you differentiate whether it is a infiltration of the skin and then producing an ulcer, or it is a your stretching as causing that ulcer?
So infiltration of the skin, there will be changes of PUD orange.
No, we are not talking about that. We are talking about the ulcer. Now you said ulcer. The reason you
Yes,
are saying it is a rapidly spreading, the skin is stretched, so it is producing ulceration. So
yes,
when
sir.
there's a skin is stretched and ulcerating, that is not a skin infiltration.
Yes, sir.
So prop test, sir.
So you think
Sir, not able to hear you, sir.
okay. Why do you think you ask the history of backache? What is the importance?
Sir, to rule out the metastasis, sir.
Metastasis where?
Metastasis to spine, sir.
No, spine is from cervical to the lumbar. We have a long spine. Which spine
Yes,
you are
sir.
interested?
Lumbar spine,
Which
sir.
spine you are interested?
Lumbar spine, sir.
Lumbar spine. Now, how from the breast you reach to the lumbar spine?
Sir, from the
You asked
posterior.
about previous breast surgeries. What surgeries were you interested to know about?
Sir, ma'am, previous surgery which might she might have underwent for any benign breast lesion, ma'am.
What surgeries?
For any benign breast lesion, ma'am, suspecting any atypical ductal hyperplasia.
Benign breast disease.
Yes, ma'am.
Only benign breast disease or anything else?
Or any previous malignant lump also, ma'am, which may be suggestive of recurrence of the breast cancer.
Okay.
Somebody undergoing excision of fibroadenoma is prone for malignancy.
No, sir.
That's what you said in the brain lesions and some surgery you said.
Sir, suspected benign lump.
See, most of the time what happens
On
is the
excision,
person
after
would have
excision
had a
biopsy,
lump.
when a tissue diagnosis has come as
So the lump would
atypical
have
ductal
not gone in for
hyperplasia,
biopsy
which
at
has
all
the chances
sometimes,
of
private
sir.
setup.
Yes, ma'am.
So that has to be kept in mind, especially when a person
Yes,
has
ma'am.
undergone a previous surgery.
Yes, ma'am.
Okay. And what is the reason
You
for
said
this
there is
nipple
a
retraction?
nipple retraction.
Yes, sir. Sorry, sir.
No, madam is asking what is the reason for nipple retraction?
Sir, involvement of lactiferous ducts, sir. When the lump is involved in the lactiferous ducts, there will be involvement retraction of nipple.
How many lactiferous ducts will be there?
So 15 to 20 lactiferous ducts.
So you mean to say that in your case, there's lactiferous duct is involved?
Yes, sir.
Okay, you have asked about
will arise from the ducts or the nearby lump
Sorry, ma'am.
ductal can arise from the duct within the duct, no?
Yes, ma'am. It can arise, ma'am.
Infiltration of malignancy into the duct was the retraction. What is the difference between congenital nipple retraction and this malignant nipple retraction?
Congenital nipple retraction, usually if it is involving single duct, it will be slit-like retraction. And after, when the patient starts to breastfeed, the nipple gets everted to the normal position. In acquired nipple retraction or malignant nipple retraction, usually it will be involving multiple ducts. There will be circumferential retraction of nipple, ma'am.
In the history, you elicited a lot of reasons. And what is the?
Sorry, ma'am.
If your patient has any predisposing factors,
no, sir. Sir, I'm not able to hear you properly.
What is the Gale's index?
Sir, Gale index and Gale index is a risk assessment scoring system, sir. Which various parameters are.
What are the factors considered?
Sir, age of the patient.
What are the parameters?
Sir, age of the patient, sir.
What is the age?
Sir, less than 12 to 14 and more than 14 years of age, sir.
So age of menarche of the patient.
Yes, sir.
Okay. Then, what is the significance of if they get the early menarche?
Sir, early menarche, the cumulative exposure of the estrogen will be more, sir.
Why?
First few cycles of menarche will be having anovulatory cycles, sir. It will be predominantly of estrogen secretion.
Why there is anovulatory cycle in the early menarche?
Sir, there will be pituitary hypothalamic pituitary and ovarian axis is poorly developed in puberty, sir. First few cycles.
So, have you assessed the Gale's index of this patient?
No, sir.
Okay. So you are expecting this patient has gone to the level of metastasis?
Yes, sir.
So what is the complaint? Is a backache is the commonest complaint of any woman?
Yes, sir.
Would you ask it is a peculiar to the pain is due to the malignancy, secondaries?
Sir, pain which does not reduce on taking rest and even taking after analgesia, sir. Which is present at rest.
So where do you get the pain?
Sir?
Where do you get the pain?
Sir, there will be spasm of paraspinal muscles, sir.
In the vertebra, where will the secondaries goes normally?
Sir, transverse process of the vertebra, sir.
What type of secondaries?
Osteolytic lesions, sir.
Any other, because he is just 48 years, just then. Any other history you asked whether the patient is having any other secondary features, metastatic features?
Sir, metastatic to lesions to lung, abdomen, and cerebral metastasis and spine metastasis we have ruled out, sir. Only
what is the commonest metastasis to the lung?
Sir, bone metastasis, sir.
What type of complaint patient will have when the metastasis to the lung?
The breathlessness, sir. Breathlessness followed by cough and hemoptysis.
Now, due to what? Where is the lesion? What is the commonest lesion in the lung?
How we should manage it? They are asking how in lung or in the thoracic cavity the metastasis is managed.
Due to secondaries, there will be malignant pleural effusion, sir. That might cause breathlessness.
What will be the clinical finding? When the patient has malignant pleural effusion.
Sir, decreased air entry on the. Decreased air entry and auscultation, sir.
Okay. Here,
Sorry, sir.
both, even if there is a consolidation, you will get the same. If there's a consolidation, collapse, everything will produce only a decrease in the bowel sound. So how will you know it is a malignant pleural effusion?
So we can do pleural tapping and
No, before that.
on percussion we have to.
What will be the finding in the percussion?
So dullness will be there, sir.
So pertaining to family history, what are the things you want to ask?
History of similar complaints of any first degree, secondary relatives, ma'am. Any patient with patient's relatives, first or second degree relative, has been diagnosed with previously with a breast lump disease, ma'am.
What do you mean by first degree?
Mother and daughter, sir. Mother and daughter, sir.
Mother and daughter.
So what is second degree?
Ma'am, sister, grandmother, grandchildren.
Aunts, maternal aunt, paternal aunt.
Paternal aunt. Yes.
What is the, are you concerned with maternal aunt or the paternal aunt?
Ma'am, both history we have to take, ma'am. Maternal and paternal history.
Okay. What do you mean by hereditary breast cancer? What do you mean by familial breast cancer?
Ma'am, hereditary breast cancer is the inherited breast cancer with a genetic mutation will be there, and familial they'll be along with the inheritance like gene mutation. There'll be associated factors will be there, ma'am.
So gene mutation usually happens in a hereditary variety. In familial variety, you don't have this gene mutation.
Yes, ma'am.
Okay. So if you have a patient with a positive family history, what are the histories you will get from the patient?
Ma'am, the age of the at which the patient was diagnosed as with carcinoma, ma'am.
Come again?
The age of the patient relative at which the patient was diagnosed with the carcinoma of breast.
Good. The age at which the diagnosis happened, then?
Whether it was unilateral or bilateral, and the type of.
Okay. And about the outcome of the disease also, you can get it from the what has happened to that particular person, whether there was a progression of the disease or the patient went in for any recurrence at a later date after treatment, or the patient is still alive or the patient is not alive anymore. All those things will give you regarding the biology of the tumor, you can have an idea whether what kind of a thing is running in those family members, especially in the positive family history. Okay.
Yes, ma'am.
And regarding this diabetes, mellitus, hypertension, everything you have put in past history. You can put it as a comorbid history. Don't put it in the past. If a patient is going to have a diabetes, it doesn't mean that it is in the past alone. Now also is going through this diabetic status, right?
Yes. Yes, ma'am.
So don't put it in the past history. Say it is a comorbid history.
Okay, ma'am.
Go to the clinical examination. I think you can. No question is there. You can go to the clinical examination.
Yes,
good evening, sir. General physical exam.
Clinical finding. Yeah.
Yes, sir. I'll be presenting the clinical findings, sir. General physical examination. Yes, sir. General physical examination. Here is a 48-year lady, moderately built, adequately nourished, conscious, alert, and oriented to time, place, and person. The pulse rate is 76 per minute in the right radial artery, regular in rate, rhythm, and normal volume, and the condition of the vessel wall is normal. BP is 130/80 millimeter of mercury, measured over the right arm in sitting position. Respiratory rate is 40 per minute, and of thoracoabdominal in type. The patient is febrile. There is no evidence of pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. The weight of the patient is 53 kg, height 153 centimeter, and BMI of 22.6. ECG performance score of the patient is 1, and Karnofsky score is 90. Local examination, the patient is examined after informed verbal consent in a well-lit room with adequate exposure and first examined in the sitting position. This is the image of the patient. First of all, inspection. Inspection is carried out with arms by side of the body. The right breast and axilla appears to be normal. The left breast is asymmetrical compared to the right breast. It is found to be enlarged and displays superolaterally. The left nipple is displayed superolaterally compared to the opposite side, and there is a retraction of left nipple, and areola appears to be normal. The fullness is seen involving the upper outer quadrant of the left breast. Skin over the left breast is stretched, red and shiny. The solitary ulcer of size about 4x3 centimeter found in the left breast involving the upper and lower outer quadrant, which is irregular in shape with raised edge. The floor is covered with slough with mild serous discharge. The surrounding skin is found to be red and edematous. On raising arms above the head, the fullness becomes more prominent. On bending forward, the bilateral breast falls forward equally. The left axilla appears to be normal. There is red and shiny skin present over the medial side of the left arm and left inframammary area extending till the left hypochondrium. There is dilated veins presented over the anterior chest wall, and there is no bilateral supraclavicular fullness. Palpation, right breast and axilla found to be normal. Left breast, there is local rise of temperature and tenderness, and there is a solitary, well-defined lump involving the upper outer and lower outer quadrant of the left breast, measuring up about 6x5 centimeter in size, which is vertically over in shape, a regular surface, well-defined margins, which is having hard in consistency, and skin over the lump is not pinchable. Surrounding skin is found to be stretched and red, and the lump moves with the breast tissue. There is no restriction in mobility of the lump on putting the underlying muscle into contraction. And there is also a solitary ulcer of size 4x3 centimeter present involving the upper and lower outer quadrant of the left breast, which is irregular in shape, tender with everted edges. The base is formed by breast tissue. Induration is present, which is extending up to the 1 centimeter from the margin, which bleeds on touch. Then surrounding skin is found to be red and shiny. The retraction of the nipple is present, left nipple is present. Areola appears to be normal. And there is also a solitary, well-defined swelling of size 2x2 centimeter present in the left axilla, which is anterior group, horizontally oval in shape, smooth surface, mobile, firm, and which is non-tender. There is tenderness present over the paraspinal area of the left lower dorsal and upper lumbar spines. Bilateral supraclavicular foci is normal. On percussion, there is resonant node present over the lateral border of the sternum. Systemic examination. Per abdomen is soft. There is no, it's non-tender. There is no distension. There are multiple skin nodules present over the right hypochondrium, just 3 centimeter below the inframammary fold, which largest measuring is 0.5 cross 0.5 centimeter, which is circular in shape, smooth surface, hard in consistency, mobile, skin over the swelling.
Any connectivity issue?
I think there is a connection issue, sir.
Hello. Am I audible, sir? Sir, am I audible, sir?
Yes, yes.
Okay. Summary of the case: the 48-year-old postmenopause lady with a solitary hard lump in the left breast for the past 6 months, associated with ulcer with 1 centimeter induration all around for the past inframammary area is red and stretched with recent onset of left nipple retraction and lower backache and a solitary, hard, mobile left axillary lymph node with multiple right hypochondriac hard skin nodules. My diagnosis will be carcinoma of the left breast with the TNM staging C, T4B, N1, M1, stage 4. Hello.
Here you can see the inflammatory signs all around
Niveda,
the-
keep that. Niveda,
Sir?
keep that images. First images are there, no?
Yes, sir.
What's the image? Image of the person. Yes.
Necessary that you are mentioning that in which position you are examining the patient and the different position at which you are examining the patient. Similarly, on when you are describing the lesion in the axilla.
What is the, you have talked about in general examination regarding the build of the individual. What do you want to, what is the influence about it? If your patient is going to be thin or the patient is going to be obese.
Ma'am, postmenopausal obesity can be reason, can be a risk factor for carcinoma breast, ma'am. And a patient with malignancy, we should see whether the patient is having
Please
cancer.
change the photo. Please change the photo because photo like this will be for a long time. Please change the photo. Okay.
Yes, sir. Yes, sir. Okay, sir.
Otherwise, YouTube will find it very difficult. Difficult questions will be coming.
Yes, sir.
So in obesity, what is happening?
Now, postmenopausal obesity is a risk factor for carcinoma breast, ma'am. And in a patient with CA breast, ma'am, we should check for the cancer cachexia. And by knowing the BMI, we can also plan for the neoadjuvant chemotherapy, and our patient will tolerate those drugs and all. Ma'am, patient is nourished or not, we can be knowing about the BMI, height, weight of the.
Obesity and nourishment, they go together.
No, ma'am. If a well-nourished patient may not be always obese, ma'am.
And then, so what is the significance of obesity? What is happening in obesity pertaining to breast
You are
cancer?
given this Kornapsky score is 80 and the ECOG is 1. Why do you want to put the ECOG 1 for this patient?
Sir, she's only having the mild symptoms of the disease, sir. There is no limitation of the activities which she is doing, sir. Hello, sir.
So usually in obesity, what happens is there is a aromatization, which is going to happen.
Fat will be deposited morely over the hip areas, ma'am. So peripheral conversion of the estrogen will be more in such patients, ma'am.
Yeah.
You can see the broad inflammation all around the mass, breast, and as well as projection hypochondria. All around
Yes,
there are
ma'am.
so much of inflammation. And why can't we call it as an inflammatory carcinoma? Because the inflammation is extended beyond the tumor mass.
Yes,
it can be an inflammatory carcinoma. Not always.
Ma'am, in inflammatory carcinoma, pudgy-orange appearance also should be there, ma'am. Pudgy-orange appearance is not there, ma'am. And the progression is above, like more than 6 months, ma'am. It's not a rapid progression. And my age is also, age of the patient is also 48 years. Underlying mass is also palpable for this patient, ma'am.
No, it's not always that there should not be a mass in case of inflammatory carcinoma. There can be an underlying mass. Not always there should be absence of mass in the inflammatory carcinoma. This case seems to be like an inflammatory mass because the inflammation is very broad. And what do you think about the skin nodules?
Ma'am, I couldn't hear you, ma'am.
Skin nodules. What do you think about the skin nodules?
Ma'am, skin nodule is a nodule which is separate from the lump, which is having at least 2 centimeters of normal tissue in between.
What do you call it? What do you call it?
Cancer and cruise, ma'am.
Transcutaneous migration.
Satellite
What do you mean by
nodules.
satellite nodules? What do you mean by satellite nodules?
Satellite nodules is a nodule skin lesions which is separate from the original mass, ma'am, with at least 2 centimeters of normal skin.
No, ma'am. Define satellite nodules. When do you call it as satellite?
Satellite nodules are the skin manifestation of a skin involvement of a carcinoma breast, ma'am, which is which is defined as
away from the nodule, which will be away from the mass, particular mass, but within the breast boundary. Okay, within the breast boundary.
Systemic examination, you are
Satellite nodule. So this case may be a satellite nodule. You cannot simply say as skin nodule. It's a satellite nodule.
Yes, ma'am.
And it seems to be like an inflammatory carcinoma. If it is an inflammatory carcinoma, what will be the staging? Now put as T4B. M1, why do you put as M1?
Ma'am, in clinically there is she's having a recent onset of back pain, ma'am, and even skin nodules on the opposite hypochondriac region, ma'am.
Opposite hypochondriac region.
Yes, ma'am. Not in the same, ma'am. My breast lump is on the left side, ma'am. Skin nodules are on the right hypochondriac region, ma'am.
You never said about the duration of the skin nodules.
Ma'am, that patient was not aware of that, ma'am, unless we palpated for that, ma'am.
Okay.
no. Why not? It is a other lesion. Why do you want to put it as a lesion of the satellite nodule?
Only if you take FNAC, you can
It
say
could
that
be some other thing. It could not be a metastatic nodule at all.
Because it is, then you must call it as a transit nodule, not a satellite nodule. Satellite nodule by definition.
Hello, sir.
What do you mean by transit nodule? In transit lesion.
In transit.
Where you fall. Generally, where you have in transit lesion. Nodule. Malignant melanoma.
Yes, ma'am.
Malignant melanoma, where the first primary draining station, between the primary draining station and the tumor proper, in between that area, there are some malignant nodules. You call it as transit. It's more common in malignant melanoma.
Niveda, hello. Did you mention about the limb size on the left side upper arm in the examination? That has to be mentioned, no? That you have forgotten. So that is very important. And one more in this position, arm by the side, you told, and bending forward, and arm raised. In better position, these are the two. One more, what other position we prefer?
Semi-recommend position.
Yeah, semi-recommend. What is the advantage of that?
Especially in the breast will be more, palpation of the breast will be more, exposure will be good in semi-recommend position, ma'am. Palpation.
Not exposure. Here the breast tissue is equally spread. Equally spread, so that the palpation, even the smallest of the small swelling, can be well palpated.
Can you offer any differential diagnosis for your case?
One differential diagnosis which I can give is inflammatory carcinoma of breast, ma'am.
Anything else?
You felt a large mass, and you still want to take an inflammatory carcinoma? What is the criteria to say it's inflammatory carcinoma?
More than 1/3 of the breast tissue should be involved, and there should be pudgy orange appearance. Most of the time, there will not be underlying mass, will not be palpable.
So here you have a huge underlying mass you are feeling. The most significant is the skin thickening. Here you are not talking about the skin thickening at all. You are not talking about any erythematous change. Then why do you unnecessarily try to put an inflammatory carcinoma? And you have an ulcerative lesion here, nodular lesion, skin nodules you are saying. So don't mix two there. That is a very, very differential situation where you are going to get an inflammatory carcinoma. If you say sarcoid, sarcoma, cystosarcoma, that's fine. Because you say that is already tension and ulceration. That is a typical feature of that.
Undilated veins over the malignant Phyllodes tumor. That could be a possibility as a differential diagnosis. Okay.
What do you think the reason for satellite nodules in the getting a CA breast? As Madam has said, in the melanoma we talk, but what is the typical nature of the satellite nodule in the carcinoma breast? Where do you want to get? What is the peculiarity of the cutaneous lymphatics?
The cutaneous blockage happens, which due to which
the cutaneous lymphatics are segmental connection. It is a segmental. It will not have a multiple connection with the surroundings. So if there is some block happens, it will be accumulated in the particular segment and you get a nodule there.
Yes, sir.
And you said that is on percussion on the parasternal region is free. What is the intention of you to percuss there?
Sir, any internal mammary lymph nodes, sir, is present. There will be
which intercostal space you percuss?
Third, fourth, and fifth, sir.
Huh?
The
Which
third and
intercostal
fourth,
space?
sir. Third and fourth, sir. Hello, sir.
After 4, and we are able to see that is what percent.
Hello, sir.
Sir, you're not audible, sir.
The blood is supplied to the internal mammary artery.
Sir, I couldn't hear you, sir. Hello, sir.
How much blood from the internal mammary artery is supplied to the breast?
So the medial inner quadrants are supplied by the internal mammary artery.
No. Majority of that, more than 90% is supplied by the internal mammary artery, but only 4% of the nodes will go to the internal mammary nodes.
Yes.
So that is a very big paradox. Normally, when all the arteries or the vessels which are supplying will have the lymphatics, but breast is one organ which will not get the along the artery of supply you have.
Yes, sir.
So how you want to proceed for that?
In this patient, even the intraclavicular region is bulged. I think the intraclavicular nodes are seen there. On percussion, you can find out the diagnosis. Patient is there is a fullness in the intraclavicular. And on clinical examination, just because of the patient is having backache, you cannot put it as the M1 now. In the exam and all, you cannot put it as the M1.
Yes,
If the patient is complaining of back pain, you cannot put the M1. It's still MF until otherwise proven. Only if it is proven, you can put it.
They have put M1 for satellite nodules, I think. It's not for the backache. Okay, how do you want to plan in your case now?
Ma'am, after I would like to go ahead with the triple assessment, ma'am. As I've already done with the clinical examination, I would like to do radiological and pathological assessment, ma'am. Radiological, I wanted to do the USG ultrasonogram of the bilateral breast with axilla, mammogram of the opposite breast. And for since this is an advanced disease, I want to go ahead with the metastatic workup also. CT thorax of the.
You want to one second. You want to do a mammogram of where? Which one?
Opposite breast.
What? Okay.
Sorry, ma'am.
With an ulcerated lesion around, can you do a mammogram?
No, ma'am.
No. Right. So how do you differentiate? What are the findings to say in a mammogram that it's going to be malignant one?
Ma'am, there is a speculated mass will be distorted mass will be there, ma'am, and there will be thickness of the skin may be present, ma'am. Distorted of the breast architecture will be there, ma'am. Microcalcification.
Distortion, microcalcification, and speculations might be noted. Okay. Will you be able to assess the biology of the tumor with the mammogram? Whether it is a primary or a metastatic thing which is present in the breast?
No, ma'am, that you can't.
If it's going to be a metastatic lesion, usually you don't tend to have microcalcification.
Yes, ma'am.
Okay, and there might not be a speculated margins, all those things will not be there.
Yes, ma'am.
So that will be a differentiating point. Okay.
Yes.
And moreover, in case of a triple negative breast cancer, also the speculations will not be there. It will be having a
Yes, ma'am.
rounded edges and it will be having this pushing border type of appearance. In case of, right. What are the various views in a mammogram?
Ma'am, for screening mammogram, there are two views, ma'am. Medial lateral oblique view and craniocaudal view, ma'am. Whereas in diagnosis, there are four views, ma'am. 90-degree posterolateral and one spot compression view, ma'am.
Halfway through your net is getting.
Hello, ma'am. Am I
Okay.
audible,
Yeah.
ma'am?
You said
Ma'am,
it was a medial
screening
lateral and a
mammogram.
craniocaudal view, and after that,
Ma'am, for that, that is for screening, ma'am. Otherwise, there are two more views, ma'am. 90-degree lateral and spot compression view, ma'am.
okay, good. Right. So now, after done a mammogram and an ultrasonogram and having documented there is a disease, now what you want to do? You said you wanted to do.
Ma'am, I wanted to pathology.
Yeah, pathological. What do you want to do?
Ma'am, core needle biopsy of the mass, ma'am. Lump, ma'am.
Okay, what is the size of the core needle?
14-16 gauge, ma'am.
It is usually around 14.
14.
Okay, that is the one. How many cores will you take?
5, ma'am. More than 5.
What are the advantages of fecal biopsy?
How many cores will you take? At least.
At least 5, ma'am.
Okay, 3 to
More
6
than 5
cores are
inches.
mandatory. Okay.
Ma'am,
What is vacuum assisted biopsy?
Mammotome, ma'am. Vacuum assisted biopsy can be done, ma'am.
What do you mean by that? What is vacuum assisted biopsy?
Ma'am, vacuum will be created, and with that, we'll be inserting that needle inside the breast, and with the help of that vacuum, this biopsy is taken, ma'am. It can be used as a for very minimal fibroadenoma also, ma'am.
So usually in a true cut needle biopsy, you tend to cut the core of tissue with the blade. It's going to be attached there. But in a vacuum, you try to pull the core out. Okay.
With the vacuum assisted pressure.
Fine. So having now that
Not a
pathology you anticipate.
Ma'am, I couldn't hear you, ma'am. Your voice was breaking.
What is the commonest pathology you anticipate?
Ma'am, invasive ductal carcinoma, ma'am.
Okay. What are the tumors which has got a favorable histology?
Ma'am, luminal A, ma'am. Hello, ma'am. Biological classification, ma'am.
No, what are the
pathological types?
Histology. Favorable histology.
Ma'am, ductal carcinoma in situ is having a good prognosis, ma'am.
Of that, there are so
when you have an extensive ductal carcinoma, do you have a if it's an extensive ductal carcinoma in situ, still you think it will be having a good prognosis?
Comparatively, ductal carcinoma is having a good prognosis.
What are the histological types which have got a favorable prognosis? Types?
Like tall cell, insular, metriform, anthematic.
Yes, ma'am.
Papillary variant.
Papillary, medullary.
Medullary variant. Then non-combinamatous variety, ma'am.
Tubular, mucinous. Okay, these things we do have a better prognosis. Right. Okay, having now diagnosed, now what do you want to do?
I want to do for the metastatic workup is not done for this patient, ma'am. We would like to progress for the metastatic workup, ma'am.
What do you mean by metastatic workup?
See, contrast enhanced CT of the thorax, abdomen, along with the spine screening also, MRI spine, LS spine with whole spine screening also will get it done, ma'am. Along with baseline investigation of CBC, LFT, alkaline phosphatase. In alkaline phosphatase, if it is raised, we'll go ahead with bone scan also, ma'am.
You want to do all the separate investigations, and being this locally advanced breast cancer, or all these investigations can be done by a single test?
Ma'am, PET scan, but already this much inflammation is there for the patient, ma'am. So there may be a chance of false positive can be there.
So locally
What is
advanced breast cancer do PET scan.
Yes,
what is the age of your patient?
48 years, ma'am.
48 years. Okay,
Yes,
let your patient be less than around 30 years, 35 years. Now, what are
yes,
the
ma'am.
things you plan?
Ma'am, we have to do for this family history also we should ask, ma'am. And the fluorescent in situ hybridization for this genes we should check for, ma'am. ER, and HERT new K67 also we should get it done, ma'am. And genetic
That
counseling
will
for
be
the family
getting
members.
for all the. One is
Genetic counseling for the family members also we should get. Hello, ma'am. You are not audible, ma'am. Hello, ma'am.
One is the genetic counseling that you have done. What is the next thing you need to address in a young person who has gotten locally advanced breast cancer?
We have to ask by whether the patient has completed family or not. If there is any genetic predisposition, we should plan again with the bilateral salpingo oophorectomy or medical oophorectomy, ovarian ablation.
Why are you going till that end? Just stop here. First, two things to be addressed is going to be, one is fertility issues they have to be addressed to the patient before you're planning in for any therapy. And then if it's going to be a younger female, then always try to address about genetic screening, which is going to be required or not. That has to be addressed, right? These two things, apart from your routine other parameters which you have already screened for metastatic workup. Okay. So your patient doesn't have.
Hello, ma'am.
So what is the plan now?
Ma'am, since this patient. Hello, ma'am.
Niveda,
Ma'am?
you told some skin lesions. What you want to do for that? You did not mention.
I told, ma'am, FNAC of the skin lesions and ocular lymph node, I told.
Oh, okay.
Okay,
Hello,
this
ma'am.
patient doesn't have an ulcer.
Yes, ma'am.
And if the patient is going to be in young female, say around 30, then what is the modality of investigation you want to choose?
Ma'am, first we will check for the metastatic workup, ma'am. If there is no metastasis and the patient is young, ma'am, locally
Regarding the
advanced
primary.
Primary, we'll try to give neoadjuvant chemotherapy depending upon the.
No, what investigation
you want to do for a young female?
MRI breast we have to get it done for young female.
Very good. So what are the other indications for MRI?
The patients with scar recurrence, ma'am. Patient with we can distinguish between scar and recurrence, ma'am. And for an young female with BRCA, BRCA2 mutations and all, for annual splitting also we can use, ma'am. Patient with implants and breast implants we can get it done. And young females with breast and mammography for getting a better this about maxillary lymph nodes also we can use MRI with the
So regarding MRI, when are you going to do? Usually in a young female, it's preferable to go for an MRI. And especially if you're thinking in terms of a BRCA mutation, usually microcalcifications are not happening there. In those cases, you have to go in for an MRI. And you do have an axillary metastasis with an unknown primary. In those cases also, you need to go in for an MRI.
And if you're planning for breast conservation surgery also, ma'am, before that we should get the MRI.
Wonderful, right. So now your patient is in a low. What are the different types of, what is the spectrum of LABC? What are the things which are going to categorize under LABC?
Ma'am, 3A, 3B and 3A, 3B, ma'am. Any tumor more than 5 centimeter, ma'am. With the skin involvement, without skin not involvement also can be involved, ma'am. N1, N2 or more, ma'am. without
Okay.
no evidence of metastasis.
So it is not only a locally advanced, even in a local, sometimes it might be an operable breast cancer also. Okay. It doesn't mean that it is all these cancers are not operable. And even an inflammatory breast carcinoma, it also comes under this locally advanced breast cancer category. Right. Fine. So now what do you want to plan for your patient?
Ma'am, since my patient is having an ulcerative lesion over her breast, ma'am, we should plan for a mastectomy before planning for the systemic therapy, ma'am. Palliative mastectomy should be done for her, ma'am.
Why palliative mastectomy?
Ma'am, since that ma'am, since there is an ulcerative lesion, ma'am, we can't start directly with this, ma'am. And post surgery, we would like to go ahead with the chemotherapy, ma'am, which is considering of anthracyclines and cyclophosphamide 4 cycles. And followed by radiotherapy, ma'am. Ma'am? Hello, ma'am. Ma'am, since there an active ulcer is there, we can't give systemic therapy, ma'am. It will give get worsened only, ma'am. If that ulcer was not there, ma'am, we could have gone ahead with systemic therapy, ma'am.
With ulcer, you can give chemotherapy. You can get shrunk only. You can give chemotherapy.
Yes, ma'am.
This is extensive lesion, you have to give chemotherapy only. If all the skin lesions are getting vanished, then only you can proceed with this skin lesion, you cannot do MRI or you cannot do any master. Because your skin HSR is going to be started with tumor cells. How can you do a closure? Even if you do a closure, then there will be so much of tumor nodules there. You cannot do it. Either you can do neoadjuvant chemotherapy, provided there are no metastases elsewhere. Because even with metastasis, now they are trying to do mastectomy. Because oligometastasis, you don't do surgery. Nowadays, it is recommended. So you can do a trial of chemotherapy and see whether it is becoming operable. Then you can do mastectomy. Now, if you go straight away and go and do mastectomy, then at that site, there definitely these nodules will be there, and there will be ulceration again.
Yes,
ma'am. You have to treat system.
Ma'am, these nodules are on the opposite. Nodules are on the opposite breast, ma'am. No.
Nodules in the lung also you can give chemotherapy, ma'am. Now there are trials of oligometastasis. You can give chemotherapy and you can proceed with MRI.
Yes, ma'am.
Yes.
Is there a role for?
Yes, ma'am. Proceed.
Having done a mastectomy, is there any role for reconstruction here?
Ma'am, if closure is, since it is a huge lump, ma'am, along with this, along with the ulceration is also there, ma'am. If closure is not happening, ma'am, we can go for flap.
So what should be done?
Flap can be kept, ma'am.
In this case, it is not possible now. You said the tumor nodules are in the opposite side now. There is no role for direct surgery and flap reconstruction.
Yes, ma'am.
You have to definitely give chemotherapy. You have to
Yes,
treat
ma'am.
the system. Then only you can do all these things. What all these things.
Yes, ma'am.
This comes under, there is no metastasis, this comes under locally advanced breast cancer, inoperable subset. There is operable subset and inoperable subset. No, this comes under inoperable subset. So the treatment for inoperable subset is preoperative systemic therapy. This only you can go for first. So that's why I say. But if you find any metastasis in the extensive bone metastasis or liver or lung, there are so many metastases, then there is no chance. Then you have to do one palliative chemotherapy, palliative. hormonal therapy and palliative radiotherapy. That will be the treatment. That will take care of all the issues. And so much of ulceration, bleeding and all is present, then you have to go with palliative mask. Otherwise, you can give hormonal therapy, chemotherapy, and radiotherapy, palliative.
Yes.
What are the indications of breast conservative?
Breast conservation, first we'll for young females, ma'am, when the breast tumor ratio we should check, ma'am. And it breast should be involving only one or quadrant.
Before that, absolute indication for breast conservative surgery. You have to tell that first, then only these points.
Yes,
so which category you will do breast conservative?
Early breast cancer, ma'am.
Early breast cancer. Nowadays, in the abroad and all, even for locally advanced, they treat with the preoperative and they do oncoplastic surgery or breast conservative surgery. So whenever it is feasible, you can do breast conservative surgery.
Yes,
so absolute indications will be T1, T2, N0, N1. Nowadays, T3, N1 also, T3, N0, T3, N1 also you can do.
Yes, ma'am.
Even with after chemotherapy also you can do conservative.
Yes.
Then what are the relative contraindications? What are the contraindications of breast conservative?
The tumor involving multiple quadrants, ma'am. Pregnancy, if there is multiple microcalcification, multifocal lesions, ma'am.
What do you mean by multifocal? What do you mean by multicentric?
Multifocal lesion, there is involvement of another lesion within 4 centimeter of the one lesion, ma'am. Multicentric, if it is more than 4 centimeter or in the other breast, ma'am.
No, it's not like that. It's restricted to one particular quadrant.
Then
it is multifocal. If it is going to involve all the 4 quadrants of the same breast, we call it as multicentric. Okay. Then pregnancy, multicentricity.
Calcifications, ma'am.
Okay.
And if there is large tumor and the breast tissue is small, ma'am. Tumor to breast tissue is small.
Positive margin. Persistent positive margin cannot do breast conservation. Once or twice you can do breast conservation. More than that, if there are persistent positive margin, that is, if the margin is positive, then you have to convert to mastectomy. Yes, poorly differentiated tumors also, you have to go with mastectomy. Then these are all absolute contraindications. Then related contraindication. What is the tumor breast ratio? Then collagen vascular diseases. Collagen diseases.
Pregnancy, ma'am.
What are the incisions for the breast cancer? Breast MRM, no? What do you know about the incisions for MRM?
Modified radical mastectomy, the commonly used incision is two-wide incision, ma'am. There may Greenock incision can be done, ma'am, or Caucus incision can be done, or Grace incision can be done, ma'am.
Horse incision or modified horse incision can be done.
Horse incision, yeah.
Yes.
What is the difference between horse and modified horse? Stewards and modified stewards?
Modified stewards is the elliptical incision whose base is extending towards the axilla, ma'am, rather than a straight ellipse, ma'am.
No, it's not like that. It is a transverse elliptical incision, Stewards incision. Whereas horse is elliptical, oblique elliptical incision. Up to the lateral margin of the sternum, it is horse. When it extends to the midline, it is modified horse. Like that is
Yes.
stewards, up to the lateral margin, it is steward. When the incision extends up to the midline, it is modified steward.
Yes.
So, what chemotherapy you want to do? What are the regimens you know?
Ma'am, anthracyclines plus cyclophosphamide for 4 cycles, plus paclitaxel for another 4 cycles, ma'am.
What are the disadvantages of the anthracyclines and the cyclophosphamide, paclitaxel side effects?
Anthracyclines can be cause cardiac toxicity, ma'am. Cyclophosphamide can cause hemorrhagic cystitis, ma'am. Paclitaxel can cause peripheral neuropathies.
How do you assess the tumor? I mean, NAC after neoadjuvant chemotherapy, how do you assess the response?
Ma'am, there is a RACIST criteria, ma'am, PET RACIST. Response evaluation criteria for solid tumors, ma'am. Before starting the tumors, we will measure the size of the tumor, ma'am. And after the 2 to 3 cycles of chemotherapy, we will assess the response of the tumor, like completely responsive, partial responsive, no response, and it is aggressive tumors, recurrence tumors, ma'am. Growing tumors.
Progressive tumors.
Progressive tumors.
Not aggressive.
Yes, ma'am. Progressive.
Okay. What do you mean by concentric response? What do you mean by eccentric response?
Concentric response, if there is a reduction of more than 30% of size of the tumor, it is known as concentric response, ma'am. With the
response?
With consecutive chemotherapy, it will be increasing on the response of positive response.
So the problem with an eccentric response, what happens? It gives an appearance as if it is like a Swiss cheese appearance. So what happens is when you are going to planning for a resection and you think there is no response and you are going in for a surgery, the chances of clearance, you have to be very particular, and then you have to see there might be some tumor might be left out in the periphery, especially if you are planning in for a BCS. So this response has to be assessed properly.
What is the criteria for adjuvant chemotherapy? What is the criteria for adjuvant chemotherapy?
If the size of the tumor is more than 3 centimeter with a nodal metastasis N1 and N2, or if less than 0.5 centimeter with a triple negative volcano, so we can give for chemotherapy, ma'am. With there is evidence of oligometastasis, also we can give chemotherapy.
So what are the hormonal agents you know? Hormonal therapy, hormonal therapy.
Ma'am, it is depending upon the ERPR positive, ma'am. If ERPR positive for a premenopausal woman, we'll go ahead with the tamoxifen and raloxifene, ma'am. Postmenopausal woman, it can be aromatase inhibitor, anastrozole, ma'am. And HER2/neu2, it can be trastuzumab or pertuzumab, ma'am.
What is the dosage pattern for trastuzumab?
Trastuzumab, like 4 mg, it is different for both adjuvant and neoadjuvant chemotherapy, ma'am. Follow-up therapies, ma'am. For metastatic cancer, we'll first give a 4 mg per kg we will calculate the dose like 4 mg per kg kilo dose, and we'll give it for the first week. And maximum duration which we can give trastuzumab is for 1 year. And for the rest of 51 weeks, we will be giving 2 mg per kg dose, ma'am.
So it can be given once in 3 weeks or every week. It can be given for.
Any other added for triple negative breast cancer? Any other added drugs or anything you can give for triple negative breast cancer?
CD3/4 inhibitors, ma'am, and PARP inhibitors can be used, ma'am.
What is the name of the drugs?
Olaparib, ma'am, and PRP inhibitors, ma'am, and the CD3/4 inhibitors are
Palbociclib, ma'am.
Olaparib or pembrolizumab for triple negative?
Pembrolizumab is recombinant of HER2/neu2, ma'am. Negative.
Olaparib is PARP inhibitor, ma'am.
PARP is olaparib, ma'am.
And CDK4 and 6 inhibitor is palbociclib.
Ma'am?
Olaparib is mainly indicated. Olaparib.
With CA breast to CA ovary, ma'am. Olaparib is more for CA ovary also, ma'am. More response.
Hereditary cancers. Olaparib. You have to do ERT. You have to do olaparib.
Yes, ma'am.
What are the other hormonal agents you know? Apart from this, the tamoxifen and any other hormonal agents?
Ma'am, aromatase inhibitors, ma'am.
Apart from that?
Ma'am,
medical oophorectomy.
Chemical oophorectomy, GnRH analogs can be given, ma'am.
Yeah.
What is medical oophorectomy?
Medical oophorectomy, we can give GnRH analogs or for a premenopausal woman, ma'am, after for starting hormone, before starting hormonotherapy, we'll induce this medical oophorectomy also, ma'am, for the production of estrogen from the ovaries, ma'am. For that, we'll give anti-GnRH analogs, ma'am.
Any other drugs apart from GnRH analogs?
Growth hormone inhibitors also we can give. Stimulate.
Aminoglutamide.
Yes, ma'am.
What is aminoglutamide? Medical adrenalectomy.
Ma'am?
Medical adrenalectomy. Aminoglutamide.
Meterapon we can give, ma'am. Medical adrenalectomy. Meterapon.
So how do you classify the aromatase?
Steroidal and non-steroidal will be classifying, ma'am. Non-steroidal is anastrozole, letrozole, ma'am. Steroid, ma'am.
Reversible steroidal and irreversible non-steroidal, like that, no?
Yes, ma'am.
What we give is non-steroidal, reversible. That is anastrozole.
Letrozole.
Non-steroidal.
Exemestane, ma'am.
Exemestane and formestane.
Formestane.
So aminoglutamide, what does it do is it is something like adrenalectomy, so that the main steroid production is going to be stopped.
Yes,
yes.
Okay, thereby it helps in the peripheral aromatization and all those things will never.
Yes.
No.
So what do you know about sentinel lymph node biopsy?
The lesions with CFS with the N0 lymph node. Ma'am? N0 lymph nodes. Ma'am?
Indication.
Indication, yes.
Yes, ma'am. T2, T3 lesions with N0 lymph nodes, ma'am.
Why is T3, T4 lesion, not T1, T2?
T2 told, ma'am.
Even T2, any
T2.
tumor, there are no nodes. When there are clinically no nodes, you want to know whether there are nodes are involved or not.
Yes.
So you'll be doing sentinel lymph node biopsy.
Before
What do you mean by genomic assays?
Genomic assays. Genomic assays.
To assess the chemotherapy, whether the patient, we can give the patient chemotherapy or not, we do genomic assay, ma'am. Or whether we can skip chemotherapy.
To know the prognosis of the, whether we can just do surgery or surgery with the hormonotherapy or surgery, hormonotherapy and chemotherapy, ma'am. There are MammaPrint, Ongo type DX, ma'am, PAM 50, ma'am.
And can assist, ma'am, Indian.
So in the absence of a lymph node, whether to avoid a chemotherapy or to assess for the recurrence-free survival, to go in for a genomic assay, either in the type of oncotype DX assay or a MammaPrint or PAM50.
Yes, ma'am.
Yes. Karagir, sir, can we wind up? It's almost 10.
I think we have covered up. I was not there in the initial part, but then I think the way discussion have gone as last half an hour, I think it is more extensive. Maybe I would like to take comments from Professor Jyoti, ma'am, the professor of the students, ma'am, who permitted the students to present. And also from Professor Som Prakash Basu, sir, to give a closing comment.
I mean, it was very good presentation. I was listening, just listening. Very good preparation, very well done. It has gone to the almost extent of an MCH breast endocrine.
Thank you, sir. Thank you. Jyoti, ma'am.
Hello, sir. I'm quite happy that my students have presented in this forum and they could answer to the questions of Dr. Anandi madam especially. I'm very happy and well done. I'm proud of my students, sir.
Jyoti ma'am. Yeah,
I'm Jyoti.
Sumati ma'am, would you like to add something?
The voice was very disturbing.
Yeah, in between the connectivity was not there.
Not only for them, even for me it was there.
Yes, madam was.
Yeah.
Thank you, madam. You have taken both of you, the Sumati madam and you have taken them to very high level questions, and they could answer to your questions, and it is nice to have.
They are very good, madam. They presented very well, madam. They were
Thank
very
you so
good.
much.
Applause to you. Applause to you and
No.
thank you, Kanagavel sir, giving me this
Well done, both Karthik and Niveda and
Thank you, ma'am.
Sanjay, the previous presenter, also did a good job.
That is from
Thank
Professor
you.
Basu sir's unit, ma'am. Thank you,
Yeah.
Somprakash sir. Trust your health is okay now. Thank you for joining in spite of.
I'm better, but Dr. Huda has.
He texted me, sir, this evening
Yes,
that
yes.
he will not be able to join. Maybe
Yeah,
after a couple of
suddenly
weeks we
he
will
became ill
take
today,
him, sir.
but I think he'll be up by another few days.
Karthik and Niveda, do you have any doubts to get clarified from the national faculty here?
No, sir.
Ma'am, if there is an active lesion like ulcer or escoriation, ma'am, is there any problem like giving chemotherapy and radiotherapy will delay healing?
Not at all.
Your voice is disconnecting, Niveda.
See, you can't give radiotherapy to the ulcer, whereas you can give chemotherapy.
Yes.
Chemotherapy can
Yes,
be
sir.
given, ma'am.
Yes, sir.
Yes.
Ulcerated lesions, there are no contraindications for chemotherapy. Only if there is
Yes, ma'am.
Tumor will shrink, ma'am. The ulcer also will fade away.
radiotherapy is contraindicated.
Yes, ma'am. Yes, ma'am.
Any other questions, ma'am?
No, ma'am. No. Thank you.
In the presence of a metastatic disease, then you can say it's a palliative mastectomy.
Yes, ma'am.
Okay, but unless the metastasis is confirmed, don't use the word immediately as a palliative one. Okay, still the neoadjuvant therapy, you can go in for a curative therapy nowadays. Neoadjuvant therapy, they response very well nowadays. Right? Lot of newer drugs have come into place.
Yes.
Thank you, ma'am.
Thank you, sir.
Thank you. I think now we'll call a close for this session. 2.5 hours of intensive deliberation. I'm sure the students as well as the faculty would have equally benefited. So we look forward for yet another Friday with the 2 different cases for discussion. Good night, faculty. Good night, dear students, and good night, the students who are watching on the YouTube. Thank you very much.
Yeah. Thank you, sir. Thank you.
Good night.
Thank you.
Thank you, ma'am.